Okay, so it's 12 o'clock. A very good afternoon to all the respected speakers and dear participants. I welcome you all to the day 2 of our pediatric COVID-19 management training. We have yet another day of very interesting topics with great speakers in store for you. So without causing much of the delay, I would like to introduce you to our moderator of the day, Dr. Siddharth Kuwar. Additional professor in the Department of Pediatrics, King George Medical University, and he has a keen interest in pediatric intensive care. I welcome you, sir, and I would like you to begin with the proceedings of the day. Over to you, sir. Sir, please unmute yourself. You're not audible.
Okay, thank you, Dr. Arpita. Thank you for the kind words, and all are welcome to this interesting session. And the good thing is that this session will be followed by lunch. So just 2 lectures between this. So one is I invite Dr. Ankur Singh from IMS BHU Varanasi and request to speak on how to use non-invasive ventilation in children, BiPAP and CPAP. Dr. Ankur Singh, are you there, please?
Yes, sir. Can you hear me, sir?
Over to you.
Am I audible, sir?
Yes, sir, you're audible.
You are.
Okay, can I share my slides?
Sure, please go ahead.
Okay, sir. Are my slides visible?
Yes.
So, a very good afternoon to all of you from Varanasi. I am Dr. Ankur Singh, Professor in Pediatrics. Not for the next 1 hour, I will be dealing with the non-invasive ventilation. So, let's begin with a case. A 6-year-old male presented to emergency with a fever for 3 days, rapid breathing for 2 days. On examination, child was oriented with respiratory rate of 36 per minute, heart rate of 128 per minute, SpO2 was 90% at the room air. There was intercostal retractions were present and bilateral chest air entry was present with few cramps. Rest of the examination was within the normal range. This was the hurried examination by an emergency pediatrician. And let's see what comes. So these are the questions which need to know about this case. What is our clinical diagnosis? What is the severity of the grade of the disease? And what is the management of this child? And what is the type of respiratory support you will use? And what are the pointers to the improvement in the child? So these are our also learning objectives. I have put in a question form and I will try to answer all these questions in my next few slides. So not going to answer some of this. Let's move to the I will move to the learning goals. The learning goals with this question and keeping these questions in mind, the learning goals of this talk will be how to recognize respiratory failure, what are the strategies to treat the respiratory failure, what CPAP, BiPAP, HFNC, what is interface, what are the initial settings, and what are the monitoring in the golden 2-hour rule, and what are the predictors of success and failures and complications. So what is NIV? NIV is when we do not intubate a child. Ventilation without intubation means we are not intubating the child, still we are providing the respiratory support. That is called non-invasive ventilation. And non-invasive ventilation जो है, it could be of three types: HFNC, CPAP, and BiPAP. This is the order of the frequency in which we will use these techniques. We will be more of using HFNC, more of using CPAP, and less of using the BiPAP, because this BiPAP is usually not tolerated by our pediatric population. How this NIV is going to benefit? Whenever we put any child in NIV, it decreases the work of breathing, it increases the oxygenation, child is conscious, oriented, spontaneous breathing is present. We can also feed the child in between, child can interact with the parents, and all the complications of endotracheal intubation like barotrauma, local trauma, volute trauma is infections are avoided or overcome by this NIV. So no sedation on paralysis. When a word of caution is required here, we need not to sedate or paralyze whenever we are putting a child on NIV, and spontaneous respiration is a prerequisite before putting any child on a NIV ventilation. So when not to use NIV? Very simple. This is a clinical judgment. Whenever there is a cardiorespiratory arrest, there is no respiratory drive, we will not use an IV. Whenever the child is in shock, or whenever child is in hemodynamically unstable, upper GI bleed, whenever we have the facial injuries, child is uncooperative, child is not cooperating, the child already have pneumothorax. So these are all contraindication of not using an IV. We will not use an IV in these settings. So how the respiratory failure progresses? Whenever a disease, any respiratory disease, whenever a child is affected with any respiratory disease like pneumonia or disease associated LRTI, it starts manifest with a tachypnea. There is an increase in respiratory rate, that is called the tachypnea. Tachypnea is defined by increase in respiratory rate. When this increase in respiratory rate is accompanied with the use of accessory muscles of respiration, use of nasal flaring, use of neck muscles, use of intercostal muscles, head bobbing, that becomes respiratory distress. And when this respiratory distress progresses, then we have end organ damage in the form of CNS irritability. Child may end up in the shock, child may end up in respiratory arrest. That link to respiratory, that is called respiratory failure. So child may come to us in any of the stage. Child may come to us in the stage of tachypnea. Child may come to us in the state of respiratory distress. Child may come to us in the stage of respiratory failure. So we have to recognize these 3 points, because the treatment and the respiratory support are different for these 3 outcomes. For these three we have a different respiratory support at tachypnea stage. We will use different respiratory support at the respiratory distress stage. And whenever the child is in failure, then we will use the different type of respiratory support. A little bit about what is respiratory failure. Further it could be of lung failure, means problem is at the level of lungs, alveoli, leading to the oxygenation failure, or we also call it a type 1 hypoxic failure, or it becomes a pump failure. Pump failure means pump failure starts from your CNS, muscles and nerves. So it could be damage in anywhere in this connection. So this leads to the pump failure. Pump failure usually leads to the CO2 retention or hypercapnia, or it is also called the ventilatory failure or type 2 respiratory failure. But usually in our settings or in our day-to-day settings, our patient can have both type 1 respiratory failure and type 2 respiratory failure. So how to recognize? I have already told you about this slide. Respiratory distress is characterized by increased in respiratory rate, retractions, grunting. Grunting is usually lower respiratory sound from the lower respiratory tract, nasal flaring, head bobbing, and accessory muscles of respiration. When that is called respiration, when it becomes end organ damage, like whenever there is associated decreased level of consciousness, whenever their child is in a shock, or there are some biochemical derangements that occurred, then child lands up in a respiratory failure. This is very important to recognize. What are the strategies to treat? I have already told you, delivery of a ventilatory support without the use of an invasive ventilation is called a non-invasive ventilation. These are the things which we can use. We are talking about the hospital management of these patients and how it is going to work. NIV is linked to the alveolar recruitment and increase area available for gas exchange increases and improve the lung compliance, and it decreases the work of breathing and patient effort and allows the muscles to relax. So this is the mechanism of action for working in a case of child with respiratory distress whenever child is on NIV. Word about CPAP and BiPAP. CPAP is a continuous positive airway pressure, means there is a continuous positive pressure. And in the BiPAP, we have the two levels of positive pressure. One is inspiratory positive airway pressure, another is expiratory positive airway pressure. And that is present in the CPAP, it is present throughout the cycle. CPAP is mainly used for a type 1 hypoxic respiratory failure, usually tolerated by our infants and children. This also helpful in obstructive apnea and central apnea, and it improves the work of breathing and oxygenation. BiPAP is just like ventilator. Sometimes in the ventilator settings we find a setting of BiPAP, but there are stand-alone BiPAP also. As in the invasive ventilation, we are setting the parameter of PIP, PEEP. In the same way, in the BiPAP, we will set IP, IPAP, EPAP, FiO2, and respiratory rate, backup respiratory rate, so that in case there is a whenever child goes into apnea, that backup respiratory rate that helps in providing the positive pressure to the child. So CPAP and the BiPAP, I have already told you, reduce the work of breathing, in preventing the apnea by stenting the upper airways. BiPAP uses the two pressures. It is delivered to patient when the device senses the patient is initiating. Whenever patient is initiating breath, the pressure of BiPAP is delivered. BiPAP is a higher support than CPAP. We should know. BiPAP is a higher support than CPAP. Use of double circuit in the both cases, inspiratory and expiratory limbs are required. Use of we have to use interface, full face, oronasal face, helmet interfaces. We will see how the interfaces look. And use of heat and moisture exchanger filter we can use. Patient should be in an isolation room with the negative pressure and well ventilated room. So these are the parts of the CPAP. Here there is a humidifier. You can see there is a humidifier. Here we set the temperature of 37 degrees Celsius. Here is a flow. This is a flow meter. This is an air oxygen blender where the various levels of FiO2s are given, and in the flow usually keep the flow at the 7 liters per minute, and we can increase your FiO2 from 21% to the 100%. So usually we can give FiO2 of 100% with the help of CPAP, but there is a caveat. If any patient requires FiO2 of 100% on CPAP, that is taken as a CPAP failure. So this is very important to note. We usually give CPAP FiO2 around 50 to 60%. If our FiO2s are increasing, means our CPAP is failing. We have to move to another higher support to higher support for that child. So if anybody wants to give a FiO2 of 100% with CPAP, yes, we can give. But this FiO2 of providing 100% as CPAP is taken as a failure. You have to move to another respiratory support for this child. So these are the various humidifier I have told you. This is a Hudson prong interface. There are nostrils. This is interface. So this is a BiPAP which is present in our ward. First, you have to use to your respiratory support machine. Wherever the rule of thumb, we have to start always pressure. We have to start with the low pressure. Then we will increase the pressure according to our tidal volumes. Inspiratory pressure we will around 6 to 8 centimeters, and we set the expiratory pressure. We can titrate our FiO2. We can go from low to high or high to low. I ratio 1:2 and backup respiratory rate. So this is a BiPAP. So this is what I told you about the BiPAP, same slide. So this is a figure in which a child is being given or supported with a BiPAP. There is a BiPAP machine, and this is a limb from where the oxygen is going and the pressures are going delivered to this child. This is a nasal mask, this is not a nasal cannula. This is a nasal mask, and this child is easily tolerating this BiPAP. A word about HFNC, high frequency nasal cannula. High frequency nasal cannula, we have to, in the name of the high frequency, there are 3 H: heated, humidified, and high frequency. What is heated? Heated means we have to keep the temperature at 37 degrees Celsius. Humidified means we should have a humidified oxygen. We cannot give the dry oxygen. If we give the dry oxygen to the child, there will be drying of the airway, drying of the mucosa, and you will have problem in extubation, and there will lot of secretions will come. Heated, humidified, and high flow, because there is a flow is high, around more than 15-16 liters of flow is there. So this is a high flow device. This is a high flow nasal cannula, and we are delivering with the help of a nasal cannula. So heated, humidified, and most important, the inspiratory demands of the patient, inspiratory demands are fulfilled by this high flow nasal cannula. So this also creates PEEP effect like the CPAP, and it can also provide your FiO, deliver FiO2 from 20 room air to 100%. So again, all the things are there. This device can also give 100% FiO2. So this is a simple figure in which this is a flow meter, air oxygen blender. From here we can increase FiO2. Here from the flow meter, from here the oxygen is entering and getting heated and humidified, and again heated circuit from this inspiratory circuit to nasal cannula. It is delivered to the patient. So this is a simple figure of high flow nasal cannula. The most important parameter is a tolerance, patient tolerance. Is your patient is tolerating the HFNC, BiPAP, CPAP? Because if the patient is not tolerating all this respiratory device, that is an indication for putting the child on invasive ventilation. So we have to see the patient intolerance is very important. And what are the advantages of these devices? Child case will awake. We can also practice the proning. Agar thoda bachcha bada hai, more than 10 years, 12 years, so we can start, we can feed. So these are advantages of non-invasive ventilation. Patient must have the intact respiratory drive to benefit from HFNC. Means suppose the case of respiratory distress, also having the encephalitis, he is still having respiratory drive, but since his sensorium is not normal, we cannot put the child on CPAP and the HFNC. We have to intubate that child. His central regulation is not normal. So don't take it that patient has respiratory drive and you put the child on the HFNC. Patient have a normal sensorium, should have respiratory drive, respiratory effort. That patient should be put on the HFNC, CPAP, or non-invasive ventilation. This is recommended for patient with a mild acute respiratory failure. So how will starting? First, we will connect with the oxygen pipe, oxygen tubings. We will connect oxygen tubings, connect the air outlet tube. We'll set the FiO2 at 30%, set the humidifier temperature to 37 degrees Celsius. We set the PEEP, which we require for the child, usually 3 to 5 centimeters of water, and titrate as per the need. And then we connect the circuit to the interface and then to the patient. And then again we monitor. We will stand by the side of the patient for the next 2 hours, and we will monitor heart rate, respiratory rate, CFT, pulse. So how there is a video which I think I will show you in the last. See how a video of the CPAP, or can you, Mamta, can you start that? Do you have that video? Can we? Can you start, or I will start in the last? Am I audible? Am I audible, sir? Yes, there is a video.
CPAP, continuous positive air pressure, which is administered using compressed supply of air and oxygen from either a. In this video, we will learn about bubble CPAP machine, its assembly and its use in newborns. CPAP, continuous positive airway pressure, which is administered using compressed supply of air and oxygen from either a central source or oxygen cylinder. These are the components used during the assembly of the circuit and assembly of machine. Before attaching the bubble CPAP machine and circuit, first of all, hand hygiene and personal protective equipment are important. Hands are washed, then cap, mask, gloves and gown are donned in. These are the various equipments required. This is the water chamber, which is used to adjust the level of CPAP required by the baby. This is the safety device. These are the nasal prongs and nasal masks of various sizes, and this is the bar used for estimation of their size. This is the patient interface, which connects the circuit and the nasal prongs or mask. These are the bonnets of various size, and size is estimated by measuring head circumference with measuring tape. This is the humidifier water chamber, which is placed onto the servo or auto humidifier, and water is filled up to this black mark. This is the CPAP machine, and these are the inlets for oxygen and air. The oxygen and air inlets are connected to these. This is the water chamber, which is filled up to this mark, and it is adjusted on this stand. This is the humidifier water chamber, which is connected onto the servo. This is a safety device which is fit onto the humidifier water chamber, and various parts of the CPAP machine are. This is the humidifier, which has a screen which shows the humidifier temperature, and it has an alarm system if the temperature exceeds. It shows the alarm. This is the flow meter to adjust the flow of oxygen. Usually we set it up to the mark of 5 liters per minute. This is the blender to adjust the amount of mixture of oxygen and air. Ranges from 21% to 100% oxygen. This tubing from the flow meter is the device. Now we connect the inspiratory limb and the expiratory limb of the circuit. Inspiratory limb has two ends. One end is connected to the one end of the humidifier, and the other end is the patient end. And this is the expiratory limb, from which one part is connected to the water chamber, and the second part is the patient is connected to the patient interface. Patient interface, which has two ends. These two ends are connected to the inspiratory and the expiratory limb, and this end is connected to the nasal prong or the nasal mask. Now connecting the patient interface, connect one to the inspiratory limb and the second to expiratory limb. Now place the appropriate size bonnet over the baby's head. Bonnet should cover both the pinna properly and place just above the supraorbital margin. Velcro should be in the middle.
I think the slides, I think the video is over. Now can I share my screen? Is my screen visible? Am I audible? Okay. So this was a video showing how to start the CPAP, and it was very simple. And this type of video you can found in the YouTube also, and you can also learn. Self learning can also be done, and it is very simple. And so next about the what are the pitfalls in the NIV in the pediatric patient? What are the problems in NIV? First problem is pediatric interface. Suppose there are adult interface, and we are using adult interface into the pediatric population. So there is a problem because the adult interfaces are very big, and it will not fit to the face of the child, and there is a loss of pressure, loss of all the pressure which you are providing you will lose, and there will be no improvement in the child. Patient cooperation and level of consciousness. I told you, child should be cooperative and level of consciousness. Means ऐसा नहीं कि there is a case of encephalitis and with a respiratory drive is there, and you put that case of encephalitis on CPAP. The child should have a normal level of consciousness, and child should be cooperative for these procedures. If the patient is agitated and still does not tolerate after 1 hour, NIV is probably failing, and sedation will not resolve. Suppose the resident comes to you and calls you, sir, the saturation, child is not maintaining saturation, he is very agitated, and can I give mida to the child? No, sedation and muscle relaxants are not to be given whenever the child is on CPAP. That agitation could be an indication that your CPAP is failing. So never sedate the child whenever the child is on CPAP. Choosing the right time to introduce NIV. If the most important, right time. If the NIV is delayed and the hypercapnia has set in, means CO2 retention has first there was a stage of hypoxia, and child could not come to you in a stage of hypoxia. He has come late. Hypercapnia has set in. His consciousness has started coming down. You don't need to do an ABG to put the child on an IV. You can very well clinically decide whether this child can be put on an IV or not. Hypercapnia will lead to the decreased level of consciousness, and that child is to be intubated. That child is not to be put on CPAP. And same early intervention, good outcome. In the same way, in the intubation also, early intubation, good outcome. So we had the time is very important. Sooner the better. Adequate seal of interface to minimize there should be adequate seal like N95 mask. We have a seal around our face, and that seal is important to minimize the air leak. So these are the YouTube links. You can go and watch what is the difference between CPAP and the BiPAP. What are the word about interface? Interface is a device that fits on the patient face to deliver the pressure. Whatever pressure we are generating from CPAP and BiPAP, that pressure is to be delivered with some device, and that device is called interface. And whenever this device becomes endotracheal tube, then it becomes invasive ventilation. And that should, what are the ideal, what could be the ideal features of this interface? It should minimize air leaks, maximize the patient comfort, child should be comfortable, and it should synchronize with the ventilator. So there are various types of interfaces. Nasal cannula prongs are good. Their masks are good for our infants. Oronasal face mask is good for our older children. Total face mask is good for older children. And helmet device is very good for our adolescent population. So these are the various pictures which is showing. You already have seen your nasal cannula and nasal mask, because despite this is nasal mask, because this is nares plus this part of a nose is covered. So this is called nasal mask. Here the only nares are, points are entering into the nares. So this is nasal cannula. So these are the various figures, and these figures you can easily go and search on the internet. These are the various devices, like in A is nasal mask, B and C are oronasal mask, D and E is full face mask, and F is the helmet, and G is the nasal pillows. So these are the various type of the interfaces you have to be familiar with. So this is a child who is sleeping very nicely, comfortably, and tolerating the helmet device. Child is comfortable, non-anxious. So tolerability is one of the important factor for deciding the interface. So whatever till now we have read, this is the summary of the slides. So whenever child comes to in an emergency, we have now, you see, you remember the first case. The child came in the emergency with the 6-year-old child came in the emergency with fever and respiratory distress, with tachypnea, with tachycardia, and with the following saturation. We have to decide type 1 respiratory flu. Clinically, you can decide age of hypoxia, 90% age. The child has retractions and tachypnea, means child has moderate type of COVID. His consciousness was okay. The child has a moderate level of disease, moderate disease, or you can also say type 1 respiratory failure. You can easily choose one of two. Like you can put the child on HFNC. In that, I am talking of that child, HFNC or CPAP. Whatever is available to your again, you will use interface. What type of interface? 6 year you can use high flow. You can use high flow mask or as a nasal cannula. In case of high flow nasal cannula, we have to titrate the liters per minute according to the weight of the child. For the first 10 kg, it is 2 liters per kg per minute. For the next above the 10 kg, which is extra 10 kg, suppose it is 15 kg, the extra 5 kg it is 0.5 liters per kg per minute. Means for a child who is having a weight of 15 kg, what should be the flow of HFNC? It should be for 10 into 20 and 5 into 0.5, 2.5 means 22.5 liters per minute should be the flow, and that flow will give you the saturation of FiO2 of 95-96% and keep the saturation in your accepted range. Again, we can use CPAP also in that child, or if child is going into the level of conscience is coming down, again the child is going to the type 2 respiratory failure. So we can think, or the child is elder, adolescent child, we can think also of using BiPAP in this child. The most important, we have used our NIV devices is monitoring. We will monitor heart rate. We will stand there, monitor heart rate, respiratory rate, SpO2, FiO2, blood pressures, and we will decide that whether our this CPAP is working or not. This initial 2 hours is very important. In the next 2 hours, we will able to tell and we will able to decide that our CPAP is working. If it is working, continue with that NIV device. If it is not working, you have to move to the higher respiratory support. You have to intubate the child. So this is the rule of golden 2 hours. I was talking golden 2 hours. What are the golden 2 hours? Requires more careful observation the initial 2 hours. Child should be nil orally and put that before that period and the IV fluids. Don't feed and all that child. Monitor heart rate, respiratory pulse, SpO2, chest findings, work of breathing. What is happening nowadays is resident, you are calling the resident, what is the saturation? Resident will tell you, sir, saturation is 95%. Heart rate is 120. Bas, ho gaya monitoring. No, we have to monitor patient as a whole. Work of breathing is very important component of monitoring. Patient tolerance, synchrony, interface leak, periodic ABG gases you have to do. This will help picking early patients needing intubation. You can decide very easily whether this candidate or this child is going to tolerate CPAP or we have to move to a high respiratory support. So criteria for what are the decision to intubate? Why when our NIV is failing, child is not cooperating, child is agitated, pressures are increasing, your FiO2 requirement is increasing, child is becoming unresponsive, child is becoming unconscious. So these are all indications of using intubation, or you are finding metabolic acidosis, CO2s are increasing, in the respiratory acidosis, worsening of blood gases. Attendants and parents are refusing, no, you cannot keep the child on an IV. So not giving consent, you may have to intubate, or child is going to becoming comatose, child is getting confusion, unconscious. These are the clinical worsening. They are the indications you have to intubate. So message is, do not delay endotracheal intubation. If the patient is not improving quickly on NIV, don't hang on NIV, as this can lead to worsen the patient condition and several conditions for intubation. Because if you delay, intubation will delay, then outcome will be not good. Frequent assessment of whether the patient is improving is very critical. So what are the, we can tell now, what are the, we can predict, that is a predict, kya CPAP mera fail hoga, kya NIV fail hoga. We can predict our failures and complications based on disease severity. If disease is severe, NIV can fail. If the respiratory failure is, if type of type 2 respiratory failure, NIV may fail. Timing, if you are starting late, our intervention may fail. Or if the healthcare team is not well versed with NIV, it may fail. Suppose younger the age, chota bacha, he may not tolerate your NIV, or so in that case it may fail. If there is a high initial oxygen requirement is very much high, you are starting with 80%, 90% FiO2, high pressures, your NIV is likely to fail. And if there are underlying comorbid conditions, like child is a case of congenital heart disease, child is a case of asthma, you may find a child with a type 1 diabetes mellitus, you may find child with a nephrotic syndrome, you may find child with leukemia. These all will decide your outcome of NIV. So these are very important. And what are the complications? I have already told you. This complication could be barotrauma, volute trauma, inadequate oxygenation, inadequate ventilation, nasal dryness, gastric distension, and pneumothorax. So these are all problems with NIV. So these are all my references. So these, I want your skills to be enhanced regarding these areas. You should be able to recognize respiratory distress versus respiratory failure. You should be familiarized with the basic terms of ventilation, like what is positive inspiratory pressure, what is PEEP, tidal volume, FiO2, SpO2, minute ventilation, respiratory rate. What you have to familiarize with your devices like HFNC, CPAP, and BiPAP. You should know advantages and disadvantages, and you should also able to at least intubate the child. If you are not able to, if NIV is failing, you should be ready with intubation, and you should be able to detect whether it is failing or improving, and complication. These are the self-learning videos. So these are my contributors who contributed in building this my slides. So I thank you very much. If there are any questions, I am very happy to answer. Am I audible, Dr. Siddharth?
Yes, Dr. Ankur.
If there are any questions from the audience.
Let me see. There is a question about what are the economical options in NIV for respiratory support in older children, and any brand names for interface in CPAP, HFNC.
What are the economical options? We are not talking about economical options. These are the three options: HFNC, CPAP, and BiPAP. You have to arrange with the help of your hospital team. And there are the various types of interfaces which are available in the market, and you can do exercise on that. That exercise is already going on. I can help you if you want anything about doubt about science behind the whatever topic I took. Anything, any question about CPAP failure, CPAP complication? If anything is not clear about this, my slides or my topic, that I can tell.
Okay, then Dr. Jay Prakash Pal has asked, and whose answer is in affirmative: is nasal mask available in the market? Yes, it is very much available in market. Okay, no other question. Let's see what in chat, in case there is no.
There are no questions in the chat also. If you ask question, then there will be more interactive, and you will also learn, and I will also learn. So I will ask you question. one question which I have already asked you. Can you give a FiO2 of 100% with CPAP? Can FiO2 of 100% be delivered with CPAP? This was a question in the first presentation. There was a question from the audience. Can we give FiO2 of 100% with CPAP? Yes, surely we can give FiO2 of 100% with CPAP. But there is an important but. That but is very important, because if you are giving FiO2 of 100% with CPAP, means his respiratory drive, his oxygen requirement, his pressure requirement, his work of breathing is increasing. That is a failure of CPAP. Don't put the child on 100% and linger on the CPAP. It is failing. It is failing. So you should around 50 to 60%. If the child oxygen requirement is around 50 to 60%, slight retraction, chest retractions are there, tachypnea is there. Yeah, you can use CPAP. For that, CPAP HFNC is very good. So I think, sir, if there are no questions.
Yes, thank you, Dr. Ankur. Yeah.
Thank you, sir.
Thank you very much, Dr. Ankur. It was a very good presentation, very brief and very good. So thank you so much.
Thank you, sir.
So we move to the second talk. So let me share my screen. Please stop your presentation, Dr. Ankur. Dr. Ankur, please stop your presentation. बेटा क्लास मैं टॉक ले रहा हूँ, बताओ। हाँ बोलो, क्लास ले रहा हूँ। ठीक है बेटा, मैं लेक्चर के बीच में लेक्चर ले रहा हूँ। Okay, hello all. So my topic is oxygen therapy and delivery device systems. So objective of talking today about these things is, mine one is only introductory. So one of the advanced talk of this has already been taken by Dr. Ankur about an IV and HFNC and CPAP. So mine one is, what are options for the oxygen therapy? So learning goals for today is, this presentation is designed to improve our knowledge, skills, and clinical practice, and optimizing the use of oxygen. Important thing about oxygen is a medicine, and because oxygen is a medicine, so it can harm. We should all understand this. Just not increase our oxygenation always. Sometimes we have to take care to give as much oxygen as is needed and not more than that. Few important aspects before going ahead is the presently the wall units from where the oxygen comes piped. Usually it is sent at 4 atmospheric pressures, that is 415 kPa, and will be surprised to know that its temperature at the time of exiting from the wall or from the tube is 0 degrees centigrade. Then we blend it and we mix it with the help of say different machines and compressor with the normal air to make the percentage of oxygen and partial pressure of oxygen to go down from 21% to 200%. So it can be given with the help of fixed, or it can be given with the help of variable performance devices we'll talk about later. Fixed will always give oxygen at a fixed rate, cannot be changed, and variable performance devices, we can change the flow of oxygen and therefore perhaps the percentage of oxygen being given to the patients. Oxygen as a medicine can be used intravenous, or intra-arterial, or infusion through the wall, and it can even be given externally, like in case of hyperbaric oxygen therapy. So mainly when we give it through the pulmonary route, that is through nasal this thing, the normal natural route, its absorption at rest is around 200 ml per minute when we are giving the FiO2 of 21%. That is, normal air contains 21% of oxygen. So we call it a FiO2 of 21%, and its absorption inside the lungs and the alveoli is 200 ml per minute. Oxygen can be absorbed cutaneously as well, and the rate of cutaneous absorption is 1 milliliters per minute at 1 atmospheric pressure. However, in the air, the oxygen is present about 1/5 of atmospheric pressure. So its absorption is around 2 ml per minute at atmospheric pressure through skin. Through oral or mucosal absorption, there is nil oral or mucosal absorption of oxygen. Oxygen is metabolized in all tissues. It is metabolized through cytochrome C oxidases, mitochondrial enzymes. The 90% of metabolism takes place through this place. Then oxygen clearance kinetics is always a zero order kinetics at 200 ml per minute. Its metabolites we all know is H2O and CO2. Indications of oxygen therapy are, one is to give it for supplementation. We need to supplement oxygen in cases of hypoxemia or hypoxia. It can be given as prophylaxis in case like pre-oxygenation for giving anesthesia and intubation. Oxygen can be used as an antidote in carbon monoxide and other poisonings. Oxygen can be used as a therapy in hyperbaric oxygen, where it is used as an antibiotic in case of anaerobic bacteria soiling most of the times the burns, and then hyperbaric oxygen can be given. It can be used for denitrogenation in case of pneumothorax and pneumoencephalus, where high flow oxygen, 100% oxygen given, so that nitrogen is absorbed and oxygen is left in its place. So slowly.
So your slides are not moving.
I will start moving. Presently, I am giving some introduction.
Okay, sir. Okay.
So pneumothorax and pneumoencephalus. Then oxygen can be used as a therapy in decompression sickness. There are contraindications, definite contraindications to oxygen therapy as well. Like in bleomycin use, concomitant oxygen therapy can cause pulmonary fibrosis. Paraquat toxicity, if we use concomitant high flow oxygen, it can worsen the ARDS. Then in say aspiration of acids, the ARDS is caused by aspiration acids, but if we use oxygen simultaneously, it will increase the ARDS. So we should be cautious about using oxygen. It cannot be used left and right. Complications of oxygen therapy are drying of mucous membranes, inspiration of secretions, inflammatory tracheobronchitis, depression of CNS and depression of respiratory drive, because we need some amount of carbon dioxide as well. Hypercapnia in CO2, retaining patients like COPD, so we have to use oxygen therapy with caution in COPDs. It can cause VQ mismatch in COPDs with Haldane effect. Absorption atelectasis can be caused by 100% oxygen use. Then peripheral vascular resistance increases by oxygen. So in case of shock, we have to see the type of shock before using 100% oxygen. Cerebral and coronary vasoconstriction is caused by oxygen. It can cause euphoria. And of course, we cannot forget the ROP of newborn famous. And oxygen can decrease erythropoiesis. Having said that, let's go on to our, with this introduction, let's go. What are our options for oxygen therapy? We have to know about hypoxia in COVID-19 children. So as per the slide, hypoxia in COVID-19 children and adults can be deceptive one. Child can be hypoxic, adult can be hypoxic without having significant hypoxemia in the pulse ox. So we have to be cautious about, and we have to see at the child or the adult's respiratory work, even if the child or the pulse oxygen is showing normal SpO2. We should assess the respiratory distress, PO2, SO2, SpO2, and FiO2. Indications of goals of oxygen therapy should be known. And we have talked about something. Oxygen delivery systems कौन-कौन से हैं जिनके बारे में कुछ में बात करिए, कुछ में आगे हम लोग की टॉक्स में बात होगी. And we have a video which will increase our skill about low output oxygen therapy. Let's take a case. 5 years old child Ram presents with fever, cough, difficulty in breathing. On examination, child has tachypnea. Respiratory rate is 46, which is definitely higher for this age. Chest and drawing, irritable, pale, and SpO2 is 90%. Systemic examination is normal, except there are present on auscultation bilateral cramps. What we should do about these children, we should make an initial impression. Then we should gauge what is the severity of illness. Then we should make a treatment plan, and then we should keep on monitoring whether the treatment plan is working or not. Impression. As we see the history of this child. This impression is there is a respiratory problem with presence of emergency signs. Creps are there and respiratory rate is very high. Severity can be caused if there is only respiratory distress present, or there is also respiratory failure present. Distress is usually we breathe quietly. If we have to breathe with extra effort, which is painful or which is of discomfort to us, it is respiratory distress. By having some respiratory distress, the child or we may or may not land up into respiratory failure. What we call is respiratory failure is the failure of the respiratory system even after respiratory distress or extra working to maintain the normal oxygenation of the tissue which they are needing. The respiratory failure can be of two types. There are two types, type 1 and type 2. Very easy to remember. Type 1 contains only one entity, that is hypoxia, and type 2 contains hypercarbia as well as hypoxemia. So type 1 contains only one entity and type 2 contains two entities, hypoxia as well as hypercarbia. It may be time consuming to know why the type 2 failure contains also hypoxia, but it is suffice to know at this point of time that type 2 failure is also known as ventilatory failure because carbon dioxide is actively discharged from the body. Therefore, it involves the work of muscles. And if the work of muscles and many other things fail due to any reason, then ventilation will not be performed at the normal needy rate, and therefore CO2 will start increasing. Examples are like someone is stabbed in his chest or someone has sustained rib fractures. These conditions are so painful, the patient or the person may not be breathing freely. So his movement of the chest is very minimum. So oxygen तो अंदर चली जाएगी, लेकिन कार्बन डाइऑक्साइड निकालना मुश्किल होगा. धीरे धीरे कार्बन डाइऑक्साइड बिल्डअप होती चली जाएगी. तो हमें ये हमेशा समझना है कि कार्बन डाइऑक्साइड बढ़ रही है, इसका मतलब कि मूवमेंट ऑफ चेस्ट किसी भी कारण से कम हो रहा है या नहीं हो रहा है। जैसे कि अगर किसी बच्चे ने अपनी मदर के नारकोटिक्स उठा के खा लिए और ओवरडोज हो गई, उनकी वजह से रेस्पिरेटरी सिस्टम जो कि वेंटिलेशन की या रेस्पिरेटरी मसल्स को रेगुलेट करता है वो डिप्रेस हो गया, तो भी सांस कम होगी और CO2 बढ़ जाएगी। तो CO2 बढ़ाने वाला जो रेस्पिरेटरी फेल्योर है वो टाइप 2 रेस्पिरेटरी फेल्योर है। और CO2 और केवल ऑक्सीजन घटाने वाला, जैसे कि हम बड़े हाई अल्टीट्यूड पर पहुंच जाएं तो वहाँ एम्बिएंट एनवायरनमेंट में ऑक्सीजन सैचुरेशन बहुत कम है, तो जो हाइपोक्सिया की वजह से रेस्पिरेटरी फेल्योर होगा वो टाइप 1 रेस्पिरेटरी फेल्योर होगा। तीसरी बात है कि अब हमने पता लगा लिया रेस्पिरेटरी डिस्ट्रेस है या रेस्पिरेटरी फेल्योर है, और कौन सा टाइप 2 रेस्पिरेटरी फेल्योर, टाइप 1 रेस्पिरेटरी फेल्योर में सारे ऑक्सीजन डिवाइसेस की जरूरत होती है, और टाइप 2 में या तो हम कॉज रिमूव करें या फिर हमें या तो नॉन इन्वेजिव वेंटिलेशन या फिर इन्वेजिव वेंटिलेशन की जरूरत पड़ती है, क्योंकि हमें मसल्स का काम उन डिवाइसेस से लेना पड़ता है। ट्रीटमेंट प्लान अब हमें बनाना होगा, तो जो सिम्टम्स हैं हाइपोक्सिया के उनको हमें दूर करना होगा और स्टेबलाइजेशन करना होगा। कोई रेस्पिरेटरी इमरजेंसी साइंस है, यहाँ तक कि एयरवे ब्रीदिंग सर्कुलेशन के हिसाब से अगर एयरवे में कोई प्रॉब्लम है तो हम एयरवे की प्रॉब्लम जब तक रिमूव नहीं करते तब तक हम और एग्जामिनेशन के लिए आगे नहीं बढ़ेंगे। एयरवे नॉर्मल है और चाइल्ड ब्रीथ नहीं कर रहा है या डिफिकल्टी से ब्रीथ कर रहा है, तो वी हैव टू स्टे एट दिस पॉइंट ऑफ टाइम, वी विल रिमूव दिस प्रॉब्लम and then we will move ahead for other therapies. Securing therefore airways is important. Oxygen supplementation, selection and then selection of oxygen delivery. किस चीज से ऑक्सीजन सही से दे सकते हैं, ना ज्यादा जरूरत, ना जरूरत से ज्यादा दें, ना कम दें, इज इम्पोर्टेंट। एंड देन हमारी मॉनिटरिंग कि हम क्या इफेक्ट हो रहा है, पल्स ऑक्सीमेट्री और वर्क ऑफ ब्रीदिंग क्लिनिकली और आर्टीरियल ब्लड गैसेस, ये 3 टूल्स हमारे पास रहते हैं कि हम इनको मॉनिटर कर सकें कि हमारी ऑक्सीजन थेरेपी का क्या फायदा होगा। नाउ टू चूज प्रिस्क्रिप्शन टू प्रिस्क्राइब ऑक्सीजन थेरेपी बिकॉज ड्रग कौन सी, एक तो हमारे पास कॉन्टिन्यूअस ऑक्सीजन थेरेपी की चीजें हैं, जैसे कि एट द रेट ऑफ 2 liters per minute वाया नेजल कैनुला टू मेंटेन ऑक्सीजन सैचुरेशन लेवल फॉर 90 to 94% या थोड़ा से ज्यादा, ये लो फ्लो डिवाइस है। या नॉन ब्रीदिंग मास्क 12 liters per minute, 6 liters per minute से ज्यादा जिन डिवाइसेस में ऑक्सीजन फ्लो की जरूरत पड़ती है उनको हम हाई फ्लो डिवाइसेस कहते हैं। इवन नेजल कैनुला कैन बी यूज एज अ हाई फ्लो डिवाइस, जैसा कि भी डॉक्टर साहब ने हाई फ्लो नेजल H3FNC बोलते हैं। 3 H होते हैं क्योंकि हाई फ्लो भी होना चाहिए, ह्यूमिडिफाइड भी होना चाहिए और हीटेड भी होना चाहिए, तो 3 H के एलिमेंट्स होने चाहिए, इसलिए H3FNC is one of the mode of या instruments of oxygen therapy। दूसरा असेसमेंट, क्लिनिकल असेसमेंट तो बहुत ही जरूरी है। टाइप 1 रेस्पिरेटरी फेल्योर है कि टाइप 2 है, अगर टाइप 1 रेस्पिरेटरी फेल्योर है तो उसमें रेस्पिरेटरी रेट तो ज्यादा होगी पर डिफिकल्ट नहीं होगी, और कम अगर हो रही है तो हमेशा टाइप 2 रेस्पिरेटरी फेल्योर है, क्योंकि मसल्स मूव नहीं कर रही हैं। अगर चेस्ट मूवमेंट बहुत कम हो रहा है तो हम देख के ही कह देंगे भैया इसमें तो हाइपर कार्बिया भी है। पेरिफेरल ऑक्सीजन सैचुरेशन कितना है ये हमें पल्स ऑक्सीमीटर से देखना है, और हीमोडायनेमिक्स हमें देखनी है, और क्लिनिकली बच्चे की कंडीशन देखनी है, पेल तो नहीं हो रहा है, साइनोसिस तो नहीं हो रही, रेस्पिरेटरी, जैसे कि इस बच्चे में हमने देखा कि रेस्पिरेटरी रेट बहुत ज्यादा है। देन आर्टीरियल ब्लड गैसेस एंड SpO2 में आर्टीरियल एंड ऑक्सीजन पार्शियल प्रेशर हमें देखना होता है, वो हम ब्लड गैसेस में PaO2 देखते हैं जो कितना डिसॉल्व है प्लाज्मा में ऑक्सीजन, फ्रैक्शन ऑफ इंस्पायर्ड ऑक्सीजन हम देखते हैं कि कितनी हम FiO2 दे रहे हैं। इन दोनों का रेशियो जो है FiO2 एंड PaO2 एंड FiO2 का, इसको हम PF रेशियो बोलते हैं। लो ऑक्सीजनेशन स्टेट्स में बच्चे की, जैसे कि RDS, ये कम हो जाता है। 300 से कम में हम कहते हैं कि ये एक्यूट लंग इंजरी है, 200 से हम कहते हैं कि नहीं ये तो ARDS है। लेकिन नई डेफिनेशंस के हिसाब से ALI को अब ना मानते हुए लेस देन 200, लेस देन 300 को ही हम ARDS मानते हैं। ALI जैसी चीज अब नहीं है, क्योंकि कई स्टेजेस हो सकती हैं ARDS के डेवलप करने की। PaO2 और FiO2 बार बार करने के लिए हमें बार बार आर्टीरियल ब्लड गैसेस करनी पड़ती थी, तो कुछ लोगों ने ये सुझाया कि क्यों ना हम इसको जो हम पल्स ऑक्सीमीटर है उसकी रीडिंग जो कि SpO2 होती है उससे FiO2 का रेशियो ले लें, और क्या इन दोनों में कोई रिलेशन भी है? तो हाँ, इन दोनों में बड़ा अच्छा रिलेशन पाया गया। जो FiO2 वाला PF रेशियो है और जो SpO2 वाला SF रेशियो है, अगर SF रेशियो 235 है तो PF रेशियो 200 होगा। यानी कि जब हम ये कहते हैं कि PF रेशियो 200 से कम है इसलिए RDS है, वही हम SF रेशियो जो कि अब बड़ा इजी है, सामने ही हमेशा SpO2 आता रहता है, FiO2 वही रखना है और SfO2 जगह SpO2 रख देंगे। तो 235 अगर SF रेशियो आ रहा है तो इसका मतलब ARDS है। इसी तरह 315 अगर आ रहा है तो ये करस्पॉन्ड करता है 300 ऑफ PF रेशियो। इसका मतलब ये हो गया, ये जो हम SF रेशियो यूज करते हैं अच्छा टूल है, PaO2 बाई FiO2 करने की हमें जरूरत नहीं है, क्योंकि बार बार हमें आर्टिकुलेट ब्लड ड्रॉ करना पड़ता है। और इस SF रेशियो की स्पेसिफिसिटी एंड सेंसिटिविटी दोनों 85% या उससे ज्यादा है। पल्स ऑक्सीमीट्री जो हम लोग यूज करते हैं, ये हमें एक बस समझने की इसमें एक ही बात है कि इसमें हम जो डीऑक्सीजनेटेड हीमोग्लोबिन है उसका रेशियो देखते हैं। पहले हम इसको केवल आर्टीरियल ब्लड में देखते थे, लेकिन दो साइंटिस्ट ने बहुत मेहनत करके, एक डॉक्टर महमूद थे, एक डॉक्टर एविया थे मोस्ट प्रॉब्ली, उन दोनों ने मिलकर मेहनत करके ये देखा कि इवन वीन्स में भी ब्लड जो बह रहा होता है उसके ब्लड के ऑक्सीजनेशन को भी हम ले करके टोटल तो जो हम निकालते हैं उसमें जो हमारे आर्टिफैक्ट्स बहुत सारे होते थे, मूवमेंट आर्टिफैक्ट्स होते थे, या फिर बहुत ही लो पल्स आ रही है तो हम लोग कहते हैं नहीं बहुत लो पल्स है इसलिए पल्स ऑक्सीमीट्री रिलायबल नहीं होगी। इस चीज को उन्होंने मैसिमो टेक्नोलॉजी से दूर कर दिया। तो मैसिमो टेक्नोलॉजी में नया जो आजकल आता है उसमें एक चीज होती है सेट टेक्नोलॉजी हम यूज करते हैं मैसिमो टेक्नोलॉजी में, और उसमें अब हमारे जो सिग्नल एक्सट्रैक्शन टेक्नोलॉजी इसको बोलते हैं। इससे मैसिमो टेक्नोलॉजी को जो आजकल जितने पल्स ऑक्सीमीटर्स और फिंगर हेल्ड पल्स ऑक्सीमीटर्स आ रहे हैं उनसे लो अगर पल्स है तब भी, और हिल रहा है कुछ हो रहा है तब भी हम SpO2 मेजर कर सकते हैं। ये इंपॉर्टेंट बात है। ये एग्जांपल्स है, ये हैंड हेल्ड पल्स ऑक्सीमीटर है, फिंगर हेल्ड पल्स ऑक्सीमीटर है, ये मल्टी पैरामीटर के फॉर्म में पल्स ऑक्सीमीटर है, और ये हमारा दिखा रहे हैं कि ये सिग्नल्स जा रहे हैं और ये सिग्नल्स आ रहे हैं। तो दोनों डायोड जो हैं एक दूसरे के अपोजिट लगाने चाहिए, बस ये हमें ध्यान देने की बात है। अब एक इंपॉर्टेंट चीज समझनी है कि SpO2 PaO2 में एक तो बात हमने पहले जान ही ली थी कि SpO2 SF रेशियो को हम PF रेशियो की तरह यूज कर सकते हैं क्योंकि दोनों में कोरिलेशन होता है। अब दोनों में क्या कोरिलेशन है, 0 और 100 डिग्री सेंटीग्रेड पर तो ठीक है, सॉरी 0 और 100 पर तो दोनों बराबर हैं, लेकिन देखिए 100 से 90 के बीच में, ये कहां से आ गया, 100 से 90 के बीच में तो ये ग्राफ जो है बहुत स्लोली मूव हो रहा है ना। ये देखिए, तो हम क्या मानते हैं, PaO2 की रिस्पेक्ट में हम मानते हैं कि 80 से 100 तक PaO2 हो तो ये नॉर्मल है, 60 से 80 PaO2 हो, ये 60 से 80 अगर PaO2 हो तो माइल्ड रेस्पिरेटरी फेल्योर है, 40 से 60 हो तो मॉडरेट रेस्पिरेटरी फेल्योर है, और 40 से नीचे ये बहुत ही सीवियर रेस्पिरेटरी फेल्योर है। तो अगर हम SpO2 देखें तो 90 तक हम देख रहे हैं, बल्कि 80 तक हम देख रहे हैं, 80 तक भी है तो ये मॉडरेट रेस्पिरेटरी फेल्योर की डेफिनेशन के आसपास आता है। लेकिन हमें नॉर्मल हमें चाहिए 90 या 90 से ऊपर, और जब हम ऑक्सीजन थेरेपी यूज कर रहे हैं तब तो हमेशा 90 से 92 के बीच में अगर हम ICU में हैं, और अगर ICU में नहीं है तो 90 से 94% के बीच में SpO2 होना चाहिए। तो ये इनके कोरिलेशंस हैं। अगर SpO2 100 से 90% के बीच में हो रहा है तो हम उसकी PaO2 वैल्यू निकालने के लिए 4 मिलीमीटर ऑफ मर्करी फॉर एवरी % रिडक्शन इन SpO2 ले लेंगे। यानी कि अगर 90% आ रहा है तो 4, इसका मतलब कि 94% PaO2 होगा। लेकिन यहाँ पे कर्व करीब करीब 45 या 30 सम डिग्री है, लेकिन इसके बाद ये एकदम से स्टीप हुआ है। अब अंतर बहुत बढ़ जाएगा। जैसे कि 90 से 80% के बीच में जब PaO2 है, तब हर 1.5% PaO2 SpO2 कम हो रहा है, तो PaO2 1% कम हो रहा है, और इसके बाद ऊपर 0.25% कम हो रहा था, और यहाँ पे 50% डिवाइड SpO2 by 2 टू रीच टू अ PaO2 लेवल। यानी कि अगर किसी का SpO2 50 है, इसका मतलब कि उसका PaO2 केवल 25-26 है। ये देखिए, ठीक है। तो इस कर्व का समझने का ये फायदा है। नाउ, इंडिकेशंस एंड गोल्स ऑफ ऑक्सीजन थेरेपी। चाइल्ड विद इमरजेंसी साइंस है, तो हमें उसको, और ब्रीद कर रहा है, तो हम उसको पहले ऑक्सीजन थेरेपी देंगे वो। और दूसरा तरीका क्या है? एनी चाइल्ड विदाउट इमरजेंसी साइंस एंड SpO2 उसका 90 डिग्री से ज्यादा है, 90 अगर परसेंटेज से ज्यादा SpO2 है, तो रेस्पिरेटरी फेल्योर में एंटर कर रहा है, माइल्ड रेस्पिरेटरी फेल्योर में, इसलिए हमें उसको ऑक्सीजन थेरेपी देना पड़ेगा। क्लिनिकल कंडीशंस देख करके अगर वर्क ऑफ ब्रीदिंग ज्यादा है, भले ही उसका SpO2 मेंटेन्ड है, हमें उसको ऑक्सीजन थेरेपी शुरू करनी पड़ेगी। कब हम स्टॉप करेंगे ऑक्सीजन थेरेपी? तो हमारा टारगेट ये होना चाहिए कि SpO2 सैचुरेशन या SpO2 हमारा वार्ड में 92 से 94% पे रहे। इससे ज्यादा है तो हम धीरे धीरे कम करना शुरू कर सकते हैं फ्लो ऑफ ऑक्सीजन, और पिको में है तो जैसे अभी हमने बात करी 90 से 92%। कुल गोल्स क्या है अदरवाइज? टू मेंटेन एडिक्वेट टिश्यू ऑक्सीजनेशन, जो हमारा अल्टीमेट गोल है। अगर एक्यूट हाइपोक्सीमिया है तो उसको हम करेक्ट करें। डिक्रीज सिम्टम्स एसोसिएटेड विद हाइपोक्सीमिया के सिम्टम्स हैं, रेस्टलेसनेस हो रही है, वर्क ऑफ ब्रीदिंग हो रही बहुत ज्यादा बढ़ी हुई है, डिक्रीज इन कार्डियोपल्मोनरी लोड है, तो फिर हम और ट्रीटमेंट करें। एक चीज बड़ी इंपॉर्टेंट मैं शेयर करना चाहता हूँ, बॉडी की 55% एनर्जी सांस को लेने की गति में जाती है। इसीलिए अगर किसी को हाइपोक्सिया हो रहा है और वर्क ऑफ ब्रीदिंग है, तो और 55% से भी ज्यादा सारी की ज्यादा एनर्जी हमारी और मेटाबॉलिज्म से हट करके ऑक्सीजन मेंटेनेंस करने की कोशिश में लग रही है, तब फिर हमारी मेटाबॉलिज्म विल गो हेवायर। इसलिए हमें ऑक्सीजनेशन हाइपोक्सीमिया को लाइटली कभी नहीं लेना चाहिए। तो हेलो, ये जरा वीडियो चला दीजिए अब। हेलो, एनीवन लिसनिंग? हेलो ललित जी, ममता एंड टीम कोई है तो वो वीडियो चला दीजिए।
जी सर।
ये वीडियो ऑन कर दीजिए।
मैं डॉक्टर राजेश मीना। आज हम इमरजेंसी वार्ड और आईसीयू में ऑक्सीजन थेरेपी कैसे देते हैं, कौन कौन सी डिवाइसेस होती है, वो उन सब के बारे में जानकारी लेंगे। तो सबसे पहले हम जानकारी लेंगे फ्लो मीटर के बारे में। इसको बोलते हैं फ्लो मीटर। देखिए, ये आपके जो है सेंट्रलाइज पैनल पे लगा होगा एक फ्लो मीटर। इसमें ये बॉबिन होता है, ये आपका वो है कंटेनर है, इसमें आपको डिस्टिल वाटर भरना है। इसमें लोअर लेवल है और एक अपर लेवल, ये दो लेवल आपको दिख रहे होंगे। आपका जो है लोअर लेवल इतना, इससे नीचे जो है पानी नहीं जाना चाहिए। अगर इससे कम है तो आपको वापस फिल करना है, अपर लेवल से ऊपर भी नहीं जाना है। और ये है आपके बॉबिन, आपको यहाँ से बस और मैक्सिमम इसमें आप 15 लीटर तक ऑक्सीजन दे सकते हैं। अब इसके बाद आता है डिवाइसेस। सबसे पहली डिवाइस है नेजल प्रॉम्प्ट, या कुछ लोग इसको नेजल कैनुला भी बोलते हैं। तो ये एडल्ट नेजल कैनुला है। इसको आपको कैसे लगाना है? इसके दो एंड है, ये पेशेंट एंड है और ये फ्लो मीटर एंड है। फ्लो मीटर एंड को आपको इसमें जाके कनेक्ट करना है इसके एग्जिट पॉइंट पे और इसको फिक्स कर देना है। उसके बाद ये दूसरा जो है एंड, आपको पेशेंट के पास जाना है, उसको बताना है कि हम आपको ऑक्सीजन दे रहे हैं, और ये दोनों नॉस्ट्रल्स में जाके फिट करना है। इसके बाद इसको पीछे से टाइट कर देना है। ये आप देख रहे हैं, ये पीछे से टाइट कर देना है, जिससे कि ये आपका प्रॉन्ग्स स्नगली फिटेड हो। ठीक है, ये हो गया हमारा नेजल कैनुला। अब इसके बारे में थोड़ी जानकारी लेते हैं कि इसको कब यूज़ करना है आपको। इसको आपको जो है, आपका कोई पेशेंट या तो ऑक्सीजन थेरेपी से जब वील कर रहे हो या इनिशियली माइल्ड टू मॉडरेट केसेस में यूज़ करना है, जहाँ पे आपके पेशेंट की ऑक्सीजन रिक्वायरमेंट मीन्स FiO2 रिक्वायरमेंट जो है 45% के आसपास हो। तो इसमें आपको कितना फ्लो सेट करना है, इसमें आप 1 लीटर से लेके और 6 लीटर तक का फ्लो देना है। मैक्सिमम 6 लीटर का फ्लो देना है, 6 लीटर से के ऊपर से फ्लो इसमें ही देना है। ये हो गया आपका नेजल कैनुला और नेजल प्रॉन्ग। इसके बाद आता है आपका, जिसको हम लोग बोलते हैं सिंपल फेस मास्क और ऑक्सीजन मास्क। ये आपको कब यूज़ करना है, जब आपके पेशेंट की ऑक्सीजन रिक्वायरमेंट और FiO2 रिक्वायरमेंट जो है 60% के आसपास हो। उस केसेस में आपको फेस मास्क या ऑक्सीजन मास्क लगाना है। इसमें भी सिंपल है, इसके भी 2 एंड है। ये आपका पेशेंट एंड हो गया, ये आपका फ्लो मीटर एंड हो गया। इसको भी फ्लो मीटर पे इसी एग्जिट एंड पे कनेक्ट करना है, और ये अपने जो है पेशेंट को, ये एंट्री पॉइंट नीचे रहेगा, ये इलास्टिक है, उसको जो है ऐसे इसके ऊपर से और ये लगा देना है इस तरीके से फिट। अगर आपकी बहुत लूजिंग है तो ये स्ट्रैप से इसको थोड़ा टाइट कर सकते हैं। ये स्ट्रैप्स है, इसके स्ट्रैप्स के थ्रू इसको टाइट कर सकते हैं। इसके बाद तीसरी डिवाइस जो है, जो आज हम डिस्कस करेंगे, वो है नॉन रीब्रीदेबल मास्क। ये आप देख रहे हैं, ये है नॉन रीब्रीदिंग रिजर्वायर बैग। ये रिजर्वायर बैग है, ये आपका सिंपल फेस मास्क है। अब इसको किस पेशेंट में यूज़ करना है आपको, जिस पेशेंट की रिक्वायरमेंट FiO2 रिक्वायरमेंट अराउंड 90 to 100% है, उसमें FiO2 रिक्वायरमेंट उन सब पेशेंट्स में यूज़ करना है। मोस्टली ICU पेशेंट्स जो सीवियर डिजीज़ के पेशेंट है, उसमें आपको ये नॉन रीब्रीदिंग फेस मास्क यूज़ करना है। इसके भी 2 पॉइंट हैं, ये आपका पेशेंट एंड हो गया, ये आपका फ्लो मीटर एंड हो गया। सिंपली इसको भी जो है फ्लो मीटर से अटैच करना है और पेशेंट पे जो है इसको सेम ऐसे ही आप लगा सकते हैं और स्ट्रैप के साथ टाइट करना है इसके साथ ऐसे, और उसके बाद आपको यहाँ से फ्लो जो है ऑन कर सकते हैं। अब इसकी जो इसमें जो है आपको 10 लीटर के फ्लो से शुरू करना है। इसमें आप ये नहीं कि 2 लीटर 3 लीटर के फ्लो में छोड़ दिया, इसको मिनिमम 10 लीटर के फ्लो से शुरू करना है, और मैक्सिमम जो है आप 15 लीटर के फ्लो पे जा सकते हैं, उससे ज़्यादा नहीं जाना है। तो उसमें मतलब 15 लीटर के फ्लो में आप कम से कम 95% FiO2 अचीव कर पाएंगे। आप देख रहे हैं, ये आपका जो है ऑक्सीजन जा रही है, वेपर्स बन रहे हैं और बैग फिल हो रहा है। तो ये पूरा कंप्लीट बैग जो है फिल होना चाहिए। Dr. Rajesh Kumar Meena, Associate Professor in the Department of Anesthesiology. Today we'll discuss about the high flow nasal oxygenation therapy. It is a high flow nasal oxygenation therapy, and we'll discuss about the also known as HFNC or HFNO. HFNO is high flow nasal oxygenation, HFNC is high flow nasal cannula. Okay. In this video, first we'll discuss what are the parts of this machine. Okay, so first part is this water, distilled water, and this is a tubing line attached to the humidifier. This is an active humidifier plate, and another part is your breathing circuit. This is humidified heated breathing circuit. See, this is the machine end. You can see it. You have to just press it there. Like this. Now this, and this is your patient end. Okay. Now coming to the another part. This is the nasal cannula. This is the nasal cannula. This is a separate part. You have to attach it with this. Now it is assembled. This is patient end. And another part is the flow meter. You can see this. This is a specifically designed flow meter to give up to a 60 liter of flow. You can see they start with a 5 liter and end up to the 15 liter of flow. You can see it. Now how will you put to your patient? Like if this is your patient, just you have to attach it like this, and this should be snugly fitted in this, and by behind you can strap it. Just make sure that this should be snugly fitted. Okay. Now coming to the settings. What settings you need to in HFNC before starting? You have to set 3 parameters. First is the flow. Start with 20 liter per minute and goes up to the 60 liter per minute in Fisher Paykel, and in some machines 80 liter per minute. Second is your temperature. You have to set at 37 degree of temperature inside the machine, and ultimately last one is a FiO2. You start with the 80% of FiO2 and go up to the 100% of FiO2. Now I will show you, will demonstrate to you that how this machine works. This is on and off button. You can see this is on and off button. These are buttons for up and down, and this is for select. Now you can see in the screen, first is the 35 degrees Celsius. This is your temperature. By push it, this is your flow. You have to set 60 liter, or you can go down. Okay. Now by this you can decrease your flow like this, 50, 40 and 25, 20 like this. Okay. And another is your FiO2. You can increase your FiO2 by increasing your flow rate. You can see that it is a 20 liter of flow, and here you can see what is FiO2. It is a 95% of FiO2. Okay, and then I will increasing it. This you can see this 30 liter, and my FiO2 is 100%. So by increasing just oxygen flow, your FiO2 is set. And the most important thing is, just you can set it your FiO2, you can decrease it, and you can increase your flow also. So these are the basic settings of high flow nasal oxygenation therapy.
Hello, am I audible?
Yes, sir, you are.
Okay, so let's move ahead. I will share again. Are these slides visible?
No, sir, not yet.
Not yet. Okay. Now are they visible?
Yes, sir.
So we were here then. So we saw in brief about oxygen delivery systems, and now oxygen system that delivers oxygen at specific flow rates and FiO2 are fixed ones. Then high flow nasal oxygenation systems and non-invasive ventilation systems. These are 3 main types of the instruments we have. Conventional oxygen therapy can be with variable performance also, like in non-rebreathing mask, in which we can increase or decrease the flows. Fixed performance system, we all know, high flow nasal oxygen system like HFNC, and non-invasive ventilation. We have the earlier in the earlier talk we have talked about NIV. Variable performance system with low flow. Insufficient to meet the patient's peak inspiratory and minute ventilatory requirements. Provides relatively stable FiO2 levels as long as respiratory rate and patterns are stable. So once we fix, they can keep on giving the oxygenation, but if the patient's clinical status changes, suppose his oxygen demand increases, so we'll have to change. Can deliver high FiO2, but actual amount will vary upon breath to breath. If the child is breathing deep, he may be having more FiO2, more fraction, more absorption of oxygen into the alveoli. Examples are nasal prongs, nasal cannulae, simple face mask, high concentration mask like partial and non-rebreathing masks. There is one important thing about these non-rebreathing masks. The oxygen balloon of these masks is connected to the connector with a very flexible and movable, say, neck. So some more than many times the neck moves and contorts itself. So oxygen flow is not there. So it is very important to keep the alignment of the balloon to the knob straight, and the balloon should remain inflated. Otherwise, child will asphyxiate. What is minute ventilation? Actually, although we can see the patient's instant SpO2, or instant tidal volume, but we do require some long-term value, so that for every breath of the child, we cannot describe or we cannot discover or know his need of oxygen. For 1 minute, what is the minute ventilation of the child gives us an idea how much of oxygen the child is breathing or he should breathe. So minute ventilation is the respiratory rate into tidal volume. Tidal volume tells us in one moment, in one breath, how much oxygen is going in or coming out. And if we multiply it with the respiratory rate of 1 minute, then we will get the minute volume. It is helpful in selection of devices and assessment of need of FiO2. So respiratory distress means the child is breathing at 20 liters per minute, and non-respiratory distress, it is almost always 5 liters per minute. So we can choose our respiratory devices. Fixed performance system, high flow system, sufficient to meet patient's peak inspiratory and minute ventilatory requirement. As we have seen, the fixed performance, as we have seen, the low flow were not able to meet these requirements. Indicated in patients with variable respiratory rate and pattern to provide appropriate FiO2 to meet a patient's respiratory demand. तो बिल्कुल सेल्फ एक्सप्लेनेटरी है. एग्जांपल्स क्या है फिक्स परफॉर्मेंस सिस्टम्स के हाई फ्लो वाले? फेस मास्क जिसकी की रेस हमने विद एंट्रेनमेंट डिवाइसेस, CPAP, BiPAP, H3FNC एंड वेंटिलेटर्स. सिलेक्शन इनमें से हम इन सारी डिवाइसेस में से कैसे करें? डिपेंड्स अपॉन एज ऑफ द चाइल्ड, साइज ऑफ द चाइल्ड, ऑक्सीजन रिक्वायरमेंट उसकी क्या है, मिनट वॉल्यूम क्या है, ह्यूमिडिफिकेशन कितना रखना है, पेशेंट कंफर्ट को भी देखना है, क्लिनिकल स्टेटस क्या है, ब्रीदिंग पैटर्न क्या है, बिल्कुल ही ब्रीथ नहीं कर रहा है या कर रहा है, एंड एफिशिएंट एंड इकोनॉमिकल यूज ऑफ ऑक्सीजन जरूरी है, नेसेसरी. इट्स अ वेरी कॉस्टली मेडिसिन. अभी हम लोग ने पिछले दिनों में देखा है कोविड-19 का जब हवॉक की पीक पे था तो ऑक्सीजन की वजह से पूरे देश में हाहाकार मच गया था. सो ऑक्सीजन is a rare and it's a costly commodity as well as medicine. So we cannot fisk it away. Humidification of oxygen. Cold, dry air increases heat and fluid loss. ठीक है, हमेशा जब भी हम सांस लेते हैं without devices, तो क्या होता है, हमारा नेजल और ओरोफेरिंजियल एरिया जो है वहां वो गर्म होता है, उसमें मॉइस्चर होती है, उसको लेते हुए एयर अंदर जाती है। इसलिए ये नेचर का अपना सिस्टम है कि जो अंदर एयर जा रही है, ऑक्सीजन कंटेनिंग एयर, वो हीटेड भी है, मॉइस्ट भी है। इसलिए हमें जो भी सिस्टम्स यूज करने हैं ऐसे यूज करने हैं जिनसे ये चीज इंश्योर्ड हो, नहीं तो हमारे सिलिया ड्राई अप हो जाएंगे, सिलियरी मूवमेंट ड्राई अप हो जाएगा और म्यूकस फ्लक्स सब जगह जम जाएंगे और ऑक्सीजनेशन या गैस एक्सचेंज ही नहीं हो पाए। मेडिकल गैसेस इंक्लूडिंग एयर एंड ऑक्सीजन हैव अ ड्राइंग इफेक्ट ऑन म्यूकोसा। अभी हम लोगों ने जब शुरुआत में जब हम लोग बात कर रहे थे तो हमने साइड इफेक्ट ऑफ ऑक्सीजन में पढ़ा था। ऑन म्यूकस मेम्ब्रेन रिजल्टिंग इन एयरवे डैमेज कर सकते हैं अगर विदाउट, इसलिए नेवर अलाउ ड्राई एयर ऑक्सीजन मिक्सचर टू गो टू द पेशेंट। बहुत बार हम लोग देखते हैं कि हमारा ध्यान नहीं गया, जो कि क्रिमिनल है। हम ये नहीं कह सकते हमारा ध्यान नहीं गया कि जो ऑक्सीजन का बॉटल है जो जिससे ऑक्सीजन जा रही है मॉइस्चराइजर की, उसमें पानी नहीं है, या पानी ले जहां पे जो 9 बारी जिससे ऑक्सीजन इंजेक्ट हो रही है उसके लेवल उसके नीचे है, वी आर डेसिकेटिंग द पेशेंट्स मेम्ब्रेन। तो इस बात का ध्यान रखना है और यही अपने सिस्टर्स को और जूनियर्स को सिखाना है। सिक्रीशंस थिक भी हो सकते हैं अगर मॉइस्चराइज ना हो, कैन बिकम थिक एंड डिफिकल्ट टू क्लियर और कॉज एयरवे इवन ऑब्स्ट्रक्शन। हाइपरवेंटिलेशन ऑफ ड्राई गैसेस कैन कंपाउंड द प्रॉब्लम्स। तो पेशेंट्स जो कि थिक कोपियस सिक्रीशंस के हैं उनमें और भी ह्यूमिडिफिकेशन का ख्याल रखना है। ऑल हाई फ्लो सिस्टम्स रिक्वायर ह्यूमिडिफिकेशन, नॉन इन्वेजिव एंड इन्वेजिव वेंटिलेशन भी ह्यूमिडिफिकेशन की जरूरत है। बस ये नेजल प्रॉन्ग्स जिनमें कि 2 लीटर पर मिनट से ज्यादा हम दे रहे हैं 2 साल से कम में, और 2 साल से ज्यादा 4 लीटर पर मिनट में दे रहे हैं, और न्यू बॉर्न में इवन 1 लीटर पर मिनट दे रहे हैं, तब हमें इनको मॉइस्चराइज करने की, ह्यूमिडिफाई करने की जरूरत है। अगर 2 साल से कम का बच्चा है तो हम उसको 1 लीटर पर मिनट में दे रहे हैं, तब हमें जरूरत मॉइस्चराइजिंग की नहीं है। 2-4 साल का बच्चा है उसको हम 3 लीटर पर मिनट पे दे रहे हैं तो अलग से ह्यूमिडिफिकेशन की जरूरत नहीं है। लेकिन न्यू बॉर्न है जिसको कि हम 0.8 लीटर्स पर मिनट भी दे रहे हैं तो ह्यूमिडिफिकेशन की जरूरत है। फेशियल मास्क फ्लो रेट्स ऑफ ग्रेटर देन 5 लीटर्स पर मिनट अगर दे रहे हैं तो ह्यूमिडिफिकेशन की जरूरत होती है, उससे कम में वो अपने आप मिक्सचर करके लोकल जो क्लोज स्पेस बन जाता है उससे मॉइस्चराइजेशन हो सकता है और हीट भी हो सकता है। जिनकी ट्रैकियोस्टमी हुई भी है उनके यहाँ तो सारा ही उन पेशेंट का मॉइस्चराइजन और गर्म करने वाला सिस्टम कट आउट कर दिया हमने, इसलिए पेशेंट विद ट्रैकियोस्टमी should always be given heated and humidified oxygen air mixture. Nasal prongs के बारे में आपने पढ़ लिया। Most common device used for mild hypoxia can be set between 1 to 6 लीटर, ये भी आपने देख भी लिया है, ये हम reinforce कर रहे हैं। 6 लीटर्स पर मिनट, इससे 24% से 40% तक FiO2 दे सकते हैं। 2 साल below 2 years 2 लीटर्स पर मिनट एंड 2 साल के ऊपर 4 to 6 liters per minute इसको दिया जाता है। FiO2 increases approximately 4% with each liter of oxygen, 1 liter per minute, 25%. जैसे 1 liter per minute is equal to 25%. इसके ऊपर जैसे जैसे हम बढ़ाते जाएंगे 4% हर लीटर के हिसाब से बढ़ता जाएगा। यानी कि जब हम 4 लीटर पर मिनट दे रहे होंगे तब कितना होगा, इसमें 75 और जोड़ दें। 100% जा 100% रही है, पहुंच कितनी रही है ये अभी हमें नहीं मालूम है क्योंकि वो मिक्स होगी। अलाउज चाइल्ड टू ईट, टॉक एंड कॉफ विदाउट इंटरप्टिंग ऑक्सीजन डिलीवरी। इसमें फायदा क्या है, बच्चा चाय भी पी सकता है, खा पी सकता है, बात भी कर सकता है, सब कुछ करता रह सकता है, और कार्बन डाइऑक्साइड रिब्रीदिंग के लिए कोई स्पेस ही नहीं है। डिफरेंट साइजेस आर अवेलेबल। सिंपल फेस मास्क ना बस आईज को बचाना होता है कि आईज को डैमेज ना करे और लोअर आईलिड्स पे अनकंफर्टेबल होता है, उसको बचाना होता है। 5 से 10 लीटर पर मिनट अगर हम इसको सेट करें तो 35 to 55% की FiO2 देता है। गैस फ्लो अगर बहुत कम है तो फिर हाइपरकार्बिया हो जाएगा, में डेवलप, इसलिए फ्लो रेट 5 से कम इसमें नहीं देना। इंक्रीजिंग एजिटेशन, रैपिड एंड डीप रेस्पिरेशन, डिस्निया, प्रोग्रेसिव लेथार्जी, सस्पेक्टेड हाइपरकार्बिया में इसका मतलब कि हम इसका फ्लो लीटर्स बढ़ाना चाहिए। एक्यूट शॉर्ट टर्म थेरेपी के लिए यूज किया जा सकता है। देन पार्शियल रीब्रीदिंग मास्क, सिंपल फेस मास्क जिसमें कि एक रिजर्वायर अटैच कर दिया, विदाउट अ वन वे वॉल। आ रही ऑक्सीजन पर नीचे से मिक्स होकर आ रही है, क्योंकि ऑक्सीजन उसमें ज्यादा है इसलिए परसेंटेज बढ़ गया है। 1/3 ऑफ एक्सपिरेशन गोज इनटू बैग एंड मिक्सेस विद ऑक्सीजन। 2/3 ऑफ जो हम एयर एक्सपायर कर रहे हैं इज वेंटेड थ्रू पोर्ट एंड लीक्स अराउंड मास्क। एक मिनट। कैन बी सेट बिटवीन 6 to 10 लीटर्स पर मिनट। 40 से 60% FiO2, उस हिसाब से हम इसको दे सकते हैं। एक्यूट शॉर्ट टर्म थेरेपी के लिए ही यूज करते हैं, लंबे समय के लिए फिर हमें ज्यादा बड़े NIV या फिर वेंटिलेटर यूज करने पड़ेंगे। ज्यादातर हमें 10 लीटर्स पर मिनट पे देना पड़ता है। नॉन रीब्रीथिंग मास्क, इट इज सिंपल फेस मास्क विद अ रिजर्वायर। अभी मैं क्लास ले रहा हूँ, मैं आपको फोन कर लूंगा 4 बजे तक, बिल्कुल लगातार बैक टू बैक क्लास है। इट इज अ सिंपल फेस मास्क विद रिजर्वायर विद 2 वॉल्व्स होते हैं इसमें, 1 or 2 valves in the exhalation port to prevent room air from entering and entraining during inspiration and a one-way valve to prevent mixing of exhaled gases में होती नहीं। इसको हम 10 to 15 लीटर पर मिनट पर दे सकते हैं और इससे हमें 80 to 95% तक ऑक्सीजन डिलीवरी दी जा सकती है। एक्यूट शॉर्ट टर्म थेरेपी रिक्वायरिंग हाई FiO2 इन इमरजेंसीज के लिए यूज कर सकते हैं। फ्रीक्वेंटली हमको देखना पड़ेगा, इंस्पिरेशन रिजर्वायर बैग इज रिक्वायर्ड टू इंश्योर दैट रिमेन्स, वही जैसे मैंने बताया कि ये इन्फ्लेटेड रहे बैलून। बैलून अगर इन्फ्लेटेड नहीं हुआ तो बच्चे को एस्फिक्सिया हो सकता है। ये एग्जांपल्स हैं इसके। यहाँ पे एक्सपायर्ड गैस आई, यहाँ से निकल गई, यहाँ पे एक्सपायर्ड गैस निकल गई, तो इसलिए यहाँ पे 100% ऑक्सीजन गई, जो कि 80 से 95% तक अंदर पहुंचाएगी। अंदर थोड़ी सी वो मिल जाएगी, है ना। तो हमारा केस था राम का। राम की कंडीशन डिटेरियोरेट होने लगी, उसकी SpO2 अब 88% आ गई और नॉन रीब्रीथिंग मास्क पे लगाया था हमने, उस पे भी अब इसका मतलब कि हमको उसकी ऑक्सीजनेशन बढ़ाना है और 88% की इसको माइल्ड हाइपोक्सीमिया तो शुरू हो गया। तो लेथार्जिक एंड ABG वैल्यूज और pH 7.24 हो गया उसका, जो कि एसिडिक है। नॉर्मल हम जानते हैं 7.35 से 7.4% तक होता है, 7.35 से 7.45 तक होता है। PaO2 70 है, जो कि वैल्यू हमारी हमने भी देखी कि 80% से करस्पॉन्ड कर रही है। इसका मतलब कि ये माइल्ड 60 to 80 वाले में माइल्ड हाइपोक्सिया, माइल्ड रेस्पिरेटरी फेलियर में जा रहा है। PaCO2 55 अगेन हाइपर कार्बिया भी हो गया इसको, PaCO2 बढ़ गई है, इसका मतलब टाइप 2 रेस्पिरेटरी फेलियर है, तभी PaCO2 बढ़ी है। एंड बाइकार्बोनेट इज 22 विच इज नॉर्मल, लेकिन 22 बाइकार्बोनेट नॉर्मल होने का मतलब यहाँ पे सब कुछ सही नहीं है। बाइकार्बोनेट की वैल्यू 22 से 24 तक होती, 22 से 26 तक होती है, तो उसको कंपेंसेट करने के लिए एसिडोसिस और बढ़ना चाहिए था, जो कि बढ़ा नहीं है। 24 से ज्यादा होना चाहिए था, बढ़ा नहीं है। तो ये रेस्पिरेटरी एसिडोसिस एज वेल एज थोड़ी बहुत मेटाबॉलिक एसिडोसिस भी हो रही है। ठीक है, तो सिवियरिटी इसकी हम निकालेंगे PF रेशियो से और SpO2 से निकालेंगे। और PaO2 70 है, FiO2 हमारी हम नॉन रीब्रीथिंग मास से दे रहे हैं, मान लिया हम 40 दे, तो इस हिसाब से हम निकाल लेंगे। हमने अभी बात करी थी कि PF रेशियो और SF रेशियो में रिलेशनशिप क्या होता है। SF रेशियो को अगर निकालना है PF रेशियो से, तो 64 प्लस 0.85 इंटू PF रेशियो इज इक्वल टू SF रेशियो। जैसे कि 235, अगर PF रेशियो 200 है तो SF रेशियो करीब करीब होगा 235। PF रेशियो 87 इसमें निकाला है और SF रेशियो निकाला उसके करस्पॉन्डिंग 110। ठीक है, ए ग्रेडियंट इस टॉक से बाहर है, अगर हमारे पास टाइम मिला तो विल टॉक अबाउट इट, लेकिन ABG में वो लोग मेरा कह रहे बताएंगे। हाइपोक्सिया इन कोविड, सिम्टम ऑनसेट ये हुए, लेकिन शुरू में हाइपोक्सिया होता रहता, पता हमें बाद, इतनी बड़ी स्लाइड का मतलब केवल एक ही है कि हमें पता बाद में चलता है कई बार कि हाइपोक्सिया तो हो रहा है, SpO2 नॉर्मल बना हुआ है, इसलिए हमें बहुत सावधान रहने की जरूरत होती है। हेलो हेलो ममता जी, एनीवन
जी सर।
लिसनिंग?
यस
हाँ,
सर।
ये चला दीजिए।
सर ये प्ले हो चुका है, फिर से चला दे।
अच्छा, ये नहीं नहीं, अच्छा ये प्ले हो, ओके ओके, थैंक यू सो
हाँ।
मच। जी जी जी, ओके। तो जो दूसरी डिवाइसेस हैं, ये हाई फ्लो नेजल सिस्टम है। इसको H3FNC हम लोग यूजुअली कहना चाहते हैं, जिससे कि इंश्योर हो जाए कि तीन चीजें हैं, हाई फ्लो हो, ह्यूमिडिटी हो, और इसमें साथ में क्या हो, मॉइस्चराइज्ड हो। ठीक है, हीटेड हाई फ्लो नेजल कैनुला, हीटेड हाई फ्लो नेजल कैनुला। ओके, तो इसमें एक ये देखिए, ये जैसे कि अभी दिखाया गया, ये फ्लो मीटर होता है। इसके अभी बारे में अभी आगे बात भी की जाएगी। ये इसका नेजल इंटरफेस है, ये ह्यूमिडिफायर लगा हुआ है, और ये इंस्पिरेटरी ट्यूबिंग है। ठीक है, इसमें क्या है, ये ऑक्सीजन ब्लेंडर है, जिसमें कि ऑक्सीजन एयर मिक्सचर जितना आप देना चाहें वो है, और ये रेस्पिरेटरी ह्यूमिडिफायर है। ये नेजल कैनुला है, ये सपोर्ट आर्म, ठीक है, सब तो मैकेनिकल चीजें हैं। ये हीटेड वायर ब्रीदिंग सर्किट इसके अंदर होता है, और ये आप इसका टेम्परेचर सेट कर सकते हैं, और ये मूव की जा सकती है व्हील्स हैं इसमें। हाई फ्लो नेजल कैनुला, हीटेड ह्यूमिडिफाइड हाई फ्लो हाई FiO2 नेजल कैनुला। HFNC इज मोर कंफर्टेबल एंड बेटर टॉलरेट। देखिए, एक इंपॉर्टेंट बात ये समझ लीजिए कि हाई फ्लो नेजल कैनुला एंड इवन नॉन इन्वेजिव, ये पहले तो बिल्कुल ही ये कहे गए थे कि नहीं, इनका यूज हमें कोविड वालों में नहीं करना है, क्योंकि के चारों ओर इनसे, ये तो डेफिनेट बात है कि इनसे क्या कहते हैं, आउटसाइड एटमॉस्फेयर में तो कोविड का एनवायरनमेंट बनता ही है। फाइनली लेकिन इतनी ज्यादा जरूरत पड़ी और सबको वेंटिलेट नहीं कर सकते, तो क्या किया जाए, इसलिए दूसरी बात है कि अब फ्री फ्लो एंड फ्री अवेलेबिलिटी ऑफ पीपीई हो गई है, तो अच्छे से पूरी तरह से पीपीई पहन के अगर हमारे पास स्टाफ है, तो हम हाई फ्लो नेजल कैनुला और नॉन इन्वेजिव ये सारी चीजें यूज कर सकते हैं। Heated humidified high flow high FiO2, HFNC is more comfortable and better tolerated by the child. फ्लशेस तो इजी है, छोटा सा कैनुला अंदर चला गया, उसके बाद फिर फ्लशेस नेजोफेरिंक्स में पूरे ऑक्सीजन भर देता है, इंप्रूव ऑक्सीजनेशन, और डेड स्पेस को, फिजियोलॉजिकल डेड स्पेस जो होती है उसको, क्योंकि हम बाईपास काफी सारा कर जाते हैं और हाई फ्लो ऑक्सीजन भर देती है उस स्पेस को, इसलिए कम कर देता है। एक्सपिरेटरी इंपीडेंस जनरेट्स एक्सटेंसिक पीप इसमें जनरेट हो जाती है, जो कि हम अलग से देते हैं, वो 4 to 6 सेंटीमीटर ऑफ वाटर पर, एंड इसलिए रेस्पिरेटरी रेट की को कम कर देता है। एंड हीटिंग एंड ह्यूमिडिफिकेशन प्रिजर्व। क्या इंडिकेशंस है, क्या कंट्राइंडिकेशंस है? फेलियर टू मेंटेन टारगेट SpO2 इसका मेन इंडिकेशन है आफ्टर यूज ऑफ फेस मास्क, ऑक्सीजन हुड, वेंचुरी मास्क एंड नॉन rebreathing मास्क। Contraindications: air leak syndromes, pneumothorax, pneumomediastinum, multi-organ compromise. Multi-organ compromise है तो मोस्टली आपको वेंटिलेशन ही करना पड़ेगा, मींस मैकेनिकल वेंटिलेशन। नॉन इन्वेजिव वेंटिलेशन भी अगर आप कर रहे हैं और 2 घंटे ट्रायल देते हुए हो गए और सही रिजल्ट नहीं आए हैं,
So sorry for the interruption. There has been a power failure from where server was presenting. So he'll be joining in a short while.
Hello, am I audible?
Yes, sir, you are.
So I will request ममता जी and company की ये slides वो मेरे पास अलग से नहीं है, तो वो project कर दें. Hello, someone there? ममता जी स्लाइड्स में ये प्रोजेक्ट कर दीजिए जो मैं शो कर रहा था. We were on HFNC.
So please just hold for a minute. I'm just displaying.
Yeah. Sure. Meanwhile, maybe like power comes. Yes. Please इसको बढ़ा दीजिए जरा. Okay. So what are the advantages? Heated and humidified gas. Standard oxygen therapy delivered through nasal cannula delivers cold, not warm and dry. So this cold and dry gas has to be arrangement for heating and humidity in our HFNC. Then it has rates of gas to match a patient's inspiratory flow demands. Patients in acute respiratory failure can become extremely maybe I will join the main because not really readable. So just give me a minute. The power has come back, so I'm oh no. Hello. हेलो, ममता जी से और थोड़ा फोकस कर सकते हैं? बड़ी ब्लर आ रही है स्लाइड, में पढ़ नहीं पा रहा हूँ।
एक मिनट सर।
हेलो, ये ब्लर्ड आ रही हैं, या तो दोबारा से जरा इनको कर लीजिए। हमारे पास पावर आई थी तो फिर वो फिर चली गई। बार बार ऐसे ही होता रहेगा तो मैं सोच रहा हूँ इसी से बोल दूं, लेकिन ये बड़ी ब्लर्ड आ रही है साइड। एक बार फिर से जाके फिर से रीशेयर करके देखिए।
It's visible.
सर ब्लर नहीं है अब सही दिख रही है।
थोड़ा ब्लर्ड ही है
नहीं आ रही
अभी।
है। अभी तो विजिबल नहीं है।
It's blurred.
वैसे मैं भी ट्राई कर रहा हूँ, मेरी पावर आ गई है, लेट्स सी क्या होता है। पावर आ गई है, होपफुली अब नहीं जाएगी, तो मैं ट्राई कर रहा हूँ इधर से। हेलो, अब नेट नहीं आ रहा है, आई एम सो सॉरी। अरे ममता
So
जी,
now
कोशिश
the
करिए लगाने
slides,
का, यहाँ पावर तो आगे
sir,
बट
the
नेट नहीं आ
slides
रहा
are visible now.
है।
The slides are visible now. You can try.
इसमें नेट नहीं आ रहा, तो बन गया नेट, नहीं आ रहा। हम्म। So I'm sorry. Thanks to the previous speaker, he finished his talk within time, so that we have, I mean, we can take a bit of time. But we were talking about HFNC. So HFNC delivers heated and humidified air. It meets the needed inspiratory demands, even if they may be high.
Okay, sir will be taking some of the time in connecting to the internet. We are so sorry for the inconvenience. It will hardly take now 2 minutes. Yes.
So we are there. HFNC. We talked about this. Indications we talked about. The contraindications are air leak syndrome, pneumothorax, pneumomediastinum, multi-organ compromise, where most of the times you will be needing only mechanical ventilation. Am I audible? Hello? Am I audible?
Yes, sir, you are.
Okay, thank you. Then frequent or recurrent apneas, so we cannot keep on adjusting every time. So CPAP is only allowed when the patient is breathing on his own, and same is for HCFNC. And if the respiratory acidosis is profound and the pH for therefore is less than 7.25, then it's not indicated. How to start? So select appropriate size nasal prongs for both neonates and pediatric patients. They should not occlude more than 75% of nares. तो उसका diameter थोड़ा सा कम रहे. Snugly fitting नहीं होने चाहिए. Maximum flows अगर premature है तो 8 liters per minute पे दे सकते हैं, और neonatal है तब भी 8 liters per minute पे दे सकते हैं. Infants को 20 liters per minute तक start कर सकते हैं, और पीडियाट्रिक एज में 25 तक. और इसमें अच्छी बात यह है कि वो कलर कोडेड है. कलर कोडेड होने से फायदा यह है कि हमें मैच नहीं करना पड़ता. प्रीमेच्योर के रेड होते हैं, न्यूनेटल के येलो होते हैं, इन्फेंट के पर्पल होते हैं, और पीडियाट्रिक में ग्रीन होते हैं. देयर वाज अ क्वेश्चन कि किस ब्रांड नेम से आते हैं HFNC. तो ये देखिए, एयरवो नाम से इनके कैनुली भी आते हैं और इनकी मशीन भी आती है. ऑप्टीफ्लो नाम से भी इनके मशीन भी आती है, और रेसमेड की भी HFNC आती है. तो 3 ब्रांड नेम से आते हैं, रेसमेड, एयरवो एंड ऑप्टीफ्लो जूनियर. Start at 0.5 to 1 liter per kg per minute and increase up to 2 liters per kg per minute. Use minimal flow that makes the baby comfortable, and target will be 90 to 94%. But even if the SpO2 is 90% or 92%, 93%, but the child is not comfortable, we'll have to see if we increase oxygen, can it make the child comfortable? If not, then we'll have to see another cause why the child is uncomfortable despite we are taking care of the hypoxia. Consider providing 3-ply mask to cover mouth and nose. ये बहुत जरूरी है, क्योंकि नहीं तो कोविड-19 हर जगह वो फैलाएगा, वायरस एनवायरनमेंट में फैलाएगा. और अपने को सबको हम लोग को पूरी वो पहननी है. क्या पहननी है? PPE. Monitor heart rate, respiratory rate, SpO2 and clinically work of breathing. If no response in 1 to 2 hours, ये सारे भी जो नॉन इन्वेजिव वाले ऑक्सीजन डिलीवरी डिवाइसेस हैं उनके लिए सच है कि थोड़ा रिस्पांस तो है, पर रिस्पांस 1 to 2 आवर्स में नहीं हुआ है तो हम सपोर्ट एक्सकेलेट करेंगे, और नहीं तो फिर हम मूव अवे कर जाएंगे. SpO2 अपॉन FiO2 अपॉन RR रेशियो के हिसाब से अगर हम देखें तो हमें पता चलेगा कि अगर ROX इंडेक्स 2 घंटे पे 2.85, 6 घंटे पे लेस देन 3.47 और 12 घंटे पे लेस देन 3.85 है, तो इसका मतलब यह है कि अब हमें मूव अप कर जाना चाहिए और दूसरा सिस्टम यूज करें या फिर मैकेनिकली वेंटिलेट करें. सेकेंड इज नॉन इन्वेजिव वेंटिलेशन, जिनके बारे में अभी डॉक्टर साहब ने अभी बात करी है आपसे. 2 तरीके होते हैं इसके, CPAP एंड BPAP. हम लोग जल्दी से रिकैपिचुलेट कर लेते हैं थोड़ा उसका पोर्शन. नो सेडेशन और पैरालिसिस नीडेड, इंटैक्ट नेचुरल एयरवे क्लियरेंस, मैकेनिज्म प्लगिंग ऑफ ETT इसमें होती नहीं क्योंकि ETT होती ही नहीं है. जबकि हमारे मैकेनिकल वेंटिलेशन जब हम करते हैं तो हमारे एक बड़ी ये प्रॉब्लम होती है, कहीं ET ब्लॉक तो नहीं हो गई होगी. क्यों? तो हमारे जब व्हेनेवर द चाइल्ड इज अनकंफर्टेबल हमें ये जरूर सोचना होता है. नो मैकेनिकल ट्रॉमा रिलेटेड टू ETT प्लेसमेंट. If no response in 1 to 2 hours after heated humidified high flow nasal cannula, तब हम इसको यूज कर सकते हैं. और कंट्राइंडिकेशन इसके वही हैं जो FNC के हैं, HFNC के हैं, यानी कि अगर न्यूमोथोरेक्स की पॉसिबिलिटी लग रही है या न्यूमोमेडियास्टिनम की पॉसिबिलिटी लग रही है, या फिर मल्टीपल ऑर्गन डिसफंक्शन की लग रही है, फेशियल इंजरीज हैं, तब हम इसको लगा ही नहीं सकते हैं, और अपर जीआई ब्लीडिंग हो रही तो बार बार हमारे ये जो इंटरफेस है सॉइल होगा, इसलिए हम उसे यूज ही नहीं कर सकते। तो बिल्कुल कॉमन सेंस की तरह से हम इसको कंट्राइंडिकेशन समझा सकते। देन देयर इज बबल सीपैप, जिसके बारे में भी आपको बताया जाएगा। बबल सीपैप सेटअप कंपोनेंट्स क्या है इसके? एक तो ह्यूमिडिफायर तो सभी में होना चाहिए, उन्हीं में है, और इनमें क्या है सीपैप में और बाईपैप में क्या अंतर है? जैसे कि अभी डॉक्टर साहब ने बताया था आप लोग को, सीपैप में केवल हम हाई फ्लो हाई पीप ही प्रोवाइड कर सकते हैं, लेकिन हम उसी पीप के साथ में हम ऑक्सीजनेशन बढ़ाने के लिए बीच बीच में ये प्रेशर बढ़ा दें, तो हर बार एक इंस्पिरेटरी हाई प्रेशर आएगा, उसके बाद फिर पीप तक वो लौट आएगा, फिर हाई प्रेशर आएगा, तो इससे हमारा हाई फ्लो जनरेट होगा, बाईपैप हो जाएगा वो, क्योंकि उसमें 2 लेवल्स हो गए। जो लोअर वाला होगा वो पीप के इक्विवेलेंट होगा, और वो जो हायर वाला होगा, जो हम क्या कहते हैं मैकेनिकल वेंटिलेशन में इंस्पिरेटरी प्रेशर देते हैं, जब हम प्रेशर कंट्रोल में रखते हैं, उसके इक्विवेलेंट सा माना जा सकता है। तो ये रेट्स हैं, इसके बारे में आप पढ़ चुके हैं, जो बहुत ज्यादा टाइम वैसे भी नहीं हम लोग वेस्ट करेंगे। CPAP delivers one constant air pressure throughout the respiratory breathing cycle, inhalation में भी, exhalation में भी। alveoli कोलैप्स ना कर जाएं, इसलिए एक लोअर लेवल CPAP लेवल हमेशा मौजूद है। पेशेंट ब्रीथ स्पॉन्टेनियसली एट अ प्रीसेट बेसलाइन प्रेशर, जो कि CPAP जिसे हम बोलते हैं। अगर वो जो मैकेनिकल वेंटिलेशन में होता है तब हम उसी लेवल को पीप बोलने लगते हैं। पेशेंट कंट्रोल्स बोथ द रेट एंड डेप्थ ऑफ, सारा कुछ कंट्रोल अभी भी यहाँ पर पेशेंट के हाथ में है। ब्रेथ रेट एंड डेप्थ ऑफ ब्रीदिंग सारी कुछ पेशेंट करेगा, केवल हमने एक लोअर लेवल दे दिया है, उससे नीचे ना जाए, सो दैट कि उसके एयरवेज कोलैप्स ना हो। When the patient's respiratory effort is sensed by flow sensors, flow through the circuit is increased to maintain a stable preset pressure. इसके टाइप्स की क्या होते हैं सीपैप के? बबल सीपैप एक तो होता है, न्यूनेट्स में बहुत यूज होता है, आपने सबने देखा होगा, फ्लो ड्राइवर, एंड देन वेंटिलेटर से भी हम सीपैप वीनिंग मोड में यूज करते हैं। एसेंशियल क्या है? फ्रैक्शनल ऑक्सीजन देने की हमारे पास इंतजाम होना चाहिए इंस्पायर्ड ऑक्सीजन के लिए। प्रेशर में सीपैप देने के लिए हमारे पास कोई ना कोई चीज होनी चाहिए, यानी कि कोई पंप डिवाइस हो, है ना, एंड वार्मिंग एंड ह्यूमिडिफिकेशन चाहिए। प्रेस्क्रिप्शन सीपैप 8 सेंटीमीटर ऑफ वाटर तक हम दे सकते हैं 5 से। रिक्वायरमेंट ऑफ सीपैप इज FiO2 21 to 100% हम इससे दे सकते हैं। प्रेशर 4 से 7 8 तक भी जा सकते हैं, जैसे भी आपने देखा। फ्लो 2 to 7 लीटर्स पर मिनट। टेम्परेचर हम यूजुअली उसका गैस का रखना चाहते हैं 37 डिग्री सेंटीग्रेड, और ह्यूमिडिटी हम रखते हैं 100% रिलेटिव ह्यूमिडिटी। इनिशिएशन कैसे करते हैं? जैसे कि डॉक्टर साहब ने बताया, और आपने उसमें भी देखा था वीडियो में, कनेक्ट टू अ पल्स ऑक्सीमीटर पेशेंट को, फिक्स द कैप साइज, राइट साइज प्रॉन्ग्स, फिशर एंड पेकेल और हडसन दोनों में से कोई भी यूज कर सकते हैं। चेक द सर्किट, कनेक्ट सीपैप सर्किट टू इंटरफेस, और अगर कुछ गड़बड़ हो रही है, अलार्म बोलेगा, ब्लेंडर से अलार्म बोलेगा, ब्लेंडिंग में गड़बड़ हो रही होगी। माल फंक्शनिंग ऑफ द ब्लेंडर का अलार्म होगा, तो हमें देखना पड़ेगा, तब तक हमें बेबी को किसी और तरीके से ऑक्सीजनेट करना होगा। लीक्स इन द सर्किट का अलार्म बोलेगा। कंडेंसेशन इन द इंस्पिरेटरी लिम्ब, यूजुअली ये जो अलार्म होते हैं इनकी साउंड्स डिफरेंट होती हैं, तो हम धीरे धीरे पहचानने लगते हैं कि अच्छा इस वजह से होगा। नो कंडेंसेशन इज एक्सपिरेटरी लिम्ब का मतलब कि इस मॉइस्चराइजेशन कम हो रहा है। इनएडवर्टेंट डिलीवरी ऑफ हाई प्रेशर्स अगर हो रहे हैं तो भी ये अलार्म बोलेगा। दूसरा बाई लेवल की बात आपसे वो पिछले लेक्चर में डिटेल में आपने पढ़ी लिया है। द प्रेशर रिक्वायर्ड ड्यूरिंग ईच ब्रेथ साइकिल, ड्यूरिंग इनहेलेशन द प्रेशर इज एट द हाईएस्ट पॉइंट सिमिलर टू सीपैप, ड्यूरिंग एक्सहेलेशन द प्रेशर ड्रॉप्स टू अ मोर टॉलरेबल लेवल मेकिंग इट इजियर टू ब्रीथ। Two levels of positive pressure therefore, IPAP and EPAP. Difference between the two levels of pressure generates the pressure support. ये क्योंकि गैसेस हमेशा हाई प्रेशर से लो प्रेशर की तरफ मूव करती है, तो ये जो प्रेशर डिफरेंस है इससे गैसेस आगे बढ़ती है। असिस्ट और स्पॉन्टेनियस मोड, यहाँ की 2 पैरामीटर्स IPAP और EPAP दोनों हम सेट करते हैं। असिस्ट कंट्रोल, स्पॉन्टेनियस टाइम मोड, अपार्ट फ्रॉम IPAP EPAP बैक टू रेस्पिरेटरी रेट नीड्स टू बी सेट। कंट्रोल मोड जो है उसमें क्या करते हैं हम आईपैप, ईपैप और आरआर, तो ये एक तरह से पूरी तरह से मैकेनिकल वेंटिलेशन विदाउट इंट्यूबेशन हो गया। ये इंटरफेसेस है डिफरेंट जो इसमें यूज करी जाती है मशीन। केस हमारा कंटिन्यूड हो गया, राम को SpO2 हमने इंक्रीज करके 94% बढ़ गई, उसको हमने लगा दिया था। आफ्टर 1 hour ऑफ HFNC हिज पल्सेस वर फास्ट, HFNC भी लगा दिया, SpO2 भी बढ़ गया, लेकिन उसकी पल्स रेट फास्ट है। पल्स रेट फास्ट तभी होंगी जब उसकी ऑक्सीजन रिक्वायरमेंट और बड़ी हो, सो दैट की कार्डियक उससे पूरा कर ली जाए। तो कंपेंसेटरी ये बढ़ गई हैं ऐसा लगता है, पल्स रेट फास्ट हो गई। कोड टू टच, ब्लड प्रेशर उसका 76/40 मिलीमीटर ऑफ मर्करी हो गया। 5 साल के बच्चे के लिए मिनिमम ब्लड प्रेशर एज इंटू 2 + 70 होना चाहिए। तो 5 साल के लिए बच्चे के लिए कम से कम 80 सिस्टोलिक ब्लड प्रेशर होना चाहिए था। इस मतलब चाइल्ड इज गोइंग इनटू शॉक, हैज गॉन इनटू शॉक। शॉक की डेफिनेशन यही है, 5th परसेंटाइल से नीचे आ जाए। 5th परसेंटाइल से नीचे आ गया है क्योंकि 5th परसेंटाइल की डेफिनेशन 5 साल के या किसी साल के बच्चे में 10 साल तक, 1 से 10 साल तक के बच्चे में है 70 प्लस एज इन ईयर्स इंटू 2, तो जो कि 80 होनी चाहिए थी, यहाँ पे सिस्टोलिक ब्लड प्रेशर 76 हो गया है और SpO2 उसका 80% रह गया है। ठीक है, तो SpO2 बढ़ाने के बाद भी हमारा उसका SpO2 अब 80% हो गया। ABG pH और कम हो गया, तब तो थोड़ा सा 7.24 था, 7.20 हो गया। PaO2 हमने उसका आर्टीरियल ब्लड गैसेस कराए, 60 आ गया और PaCO2 बढ़ के उसका 60 हो गया और बाइकार्बोनेट 15 हो गया। सीवियरिटी यानी कि बाइकार्बोनेट भी कम हो गया, मेटाबॉलिक एसिडोसिस भी हो गई, PaO2 बढ़ गया, तो इसका मतलब कि रेस्पिरेटरी एसिडोसिस भी हो गई, कंबाइंड मेटाबॉलिक एंड रेस्पिरेटरी एसिडोसिस हो गई और रेस्पिरेटरी फेलियर में बच्चा सीवियर रेस्पिरेटरी फेलियर में चला गया। और ए ग्रेडियंट हम यहाँ पे नहीं लेकिन निकाल सकते हैं, विल टॉक अबाउट, इनका टाइम बचा दो। तब फिर हम इसको क्या करना पड़ेगा, इसको हमें करना पड़ेगा हाउ टू सेटअप लो फ्लो डिवाइस, इसको हमें फिर मैकेनिकल वेंटिलेशन पे भेजना पड़ेगा। हाउ टू सेटअप लो फ्लो डिवाइसेस, इसको अभी दिखा दिया गया है। हाउ टू सेटअप HFNC, हाउ टू सेटअप NIPPV, तो ये हमारी चीजें थी जो कि जिस हमें इसके, ये एक्चुअली इंट्रोडक्टरी लेक्चर था डिवाइसेस के लिए, और ये सारी फिर से 2 चीजों की 2 बातें हो चुकी हैं, अभी इनकी बातें आगे लेक्चर में की जाएंगी। So that culminates this talk. I'm sorry for lot of disturbances. And okay. For 20 minutes. Is that all? Is that good, Dr. Arpita?
Yes, sir. Sir, if there are any questions, let's see.
There are no questions in the chat box and question answer box. Anyone wants, we can chat.
If you want to ask some
questions, I will be there around, and other speakers are also. So question and answer can be taken after lunch also. In case people may resent if we are hungry and someone is engaging others in the question and answer. So question and answer are always welcome, even after in the next talk after lunch. You can always put your questions in the question answer and we will keep on writing the answers. So no questions forthcoming. So over to you, Dr. Arpita.
I can see a question in the question answer box if you like to answer.
Okay. Dr. Ankur, these are supposed to be disposable, but they are so costly. We all are using them by cleaning them, by plasma cleaning or other methods of cleaning, and we are reusing them. Dr. Ankur. And if there is no other question, we can break for lunch, come back after 20 minutes.
2:20 p.m.
We come back at 2:20 p.m. One more question. ये तो हो गया. I think Dr. Ankur, I have answered the question. Chat में क्या है? Thank you, sir. Thank you all. Thank you for patience, and we meet at 2:20 again. तो हटी नहीं हो गया इनका, टाइप कर देते हैं सर. जी आशीष जी, गुड आफ्टरनून. हाँ.
So it's 2:20 already, and I hope that everybody would have had their lunches by now. I would like to now call upon Dr. Rajesh Kumar Meena sir, who is a faculty in IMS BHU, to present the next topic for the session, that is arterial blood gas analysis, which is a very important topic. And I would like to welcome sir. Over to you, sir.
Thank you very much. Actually, sorry for.
Please unmute yourself.
Yeah. Am I audible? Hello? Am I audible to all? Hello?
You are audible.
Yeah. Am I audible?
Yes, sir.
Okay. So let's start. Actually, first I want to say sorry to all of you as I joined late today, just because Yogi ji visited our hospital, and as being a nodal officer of COVID, and for as we are preparing for third wave, and so I was involved in that program. So I'm very extremely sorry for that. So we'll start. Today we'll start with our ABG. See, ABG is your arterial blood gas analysis. It is a point of care testing. You can do it bedside, and it should be done in all critically ill patients that you are receiving in your emergency or in your ward or in your ICU. So it is just an invasive method of doing a point of care testing by which you can assess the respiratory status, the metabolic status, and what are the electrolyte of that patients. So by doing this a simple ABG testing, and just not doing ABG testing is as good as, but interpretation of ABG is much important than doing and just ABG. So every clinician or every physician who is working in the ICU, he or she should have the proper knowledge of a basic interpretation of an ABG. By mean of basic is at least he or she should know that what is primary pathology, what is the compensation, what PF ratio is that, what electrolytes are there, and what is the base axis, and what is the anion gap. Okay, so these few things you have to see in your ABG. So today's learning objective of this session will be, what are the indication of ABG, whom to do, means paramedical staff who is trained in ABG can do, and doctors, trained medical personnel, all medical personnel or paramedical personnel can do ABG. And how to do means what are the steps of taking an ABG and how to interpret it. So coming to the indications. So as we are dealing with the per se of pediatric patients, so any sick child who is coming to your emergency ward or your ICU, you have to do an ABG. So ABG plays an important role in critically ill children with respiratory distress, as we all discussed. So it reveals your oxygenation status as well as ventilation status. Okay, adequacy of ventilation, and what is the acid base balance by measuring your pH, and a significant role in documenting and monitoring the respiratory failure. Respiratory failure means type 1 or type 2, means is it oxygenation failure or is it both? So you can differentiate by doing just a simple ABG, that your patient is just of hypoxemic failure or is having also ventilatory failure. So now how to do? You have to maintain all aseptic precautions. What equipment you will require for ABG is just a simple 23 or 25 gauge needle with a 1 ml or 2 ml syringe. Don't use 5 ml or 10 ml syringe for an ABG. First thing is just a 1 ml sample is sufficient for doing an ABG. And by using more than 2 ml syringes, the pressure you are giving to an artery, the artery get collapsed, or your sampling will be, maybe you get a mixed sample, means a venous mixing can occur. So it should be a pre-heparinized. You have iodine swab, a dry cotton, and a blood gas requisite slip with you. You have to select and locate the site, means where you want to do an ABG. The commonest site is a radial artery, as you all know. And after radial artery, the second choice will be a brachial or femoral. But first you have to see a radial artery, because it is easily compressible and you can compress it very well. Before doing an sampling, you have to perform an Allen's test. Allen's test will describe details in later, but basically what happens, Allen's test performed just to see the collaterals of your ulnar and radial artery both. Okay, the basic idea behind is that. And hold the arm supine, slightly extend the wrist, palpate the artery for the strongest arterial impulse. See, this is the picture shows how you will perform an Allen's test to see your collaterals. Okay, means first you compress both the radial and ulnar, and then you release your ulnar artery, and you can see that the blood supply is there, and your all fingers and arms. So you can, by doing this, you can see that the collaterals is okay in that patients. So this is just a picture showing how to locate the radial artery and take a sample. So before taking sample, you have to maintain our aseptic precaution with the iodine and cotton swab. Enter at the skin at the 30 to 45 degree of angle, and enter just proximal to the wrist at the level of proximal skin crease or the stellate process. So insert the needle gently but firmly in the area of maximum pulse. So you can use a 2-finger technique. Just simply you have to put it there, and where the maximum impulse you find, you can prick it. So advance and then slowly until the arterial blood is obtained, the resistance is felt. So you can see, you can feel resistance at both levels. First, you will when you will prick your artery, you will feel a resistance like you are puncturing a kite. Okay, and when you will advance it, you will feel a sharp feeling. Then it means that you hit a bone. Okay, so if resistance is felt while advancing deeper, you have to slowly withdraw. Means अब आपने bone hit किया है, so you have to withdraw it. So advancement change slightly to one side and to another. Means you can manipulate by doing right or left a little bit. Okay. If artery not get punctured after redirection sometimes, withdraw the needle, or you can call for help. In that situation, call your anesthesiologist or call your intensivist, or you can call anyone who is having expertise in taking ABG. So aspirate slowly, or I must say you need not to aspirate. The arterial pressure is much enough that your 1 ml syringe will be automatically filled, and collect at least a minimum of 0.2 ml or maximum of 1 ml will be sufficient. Withdraw the needle and apply direct constant pressure for a minimum of 5 minutes. Okay. Just keep in mind, after taking sample, you have to compress it for at least 5 minutes. Okay. Or in patients who is having coagulopathies like hepatic disease, cirrhosis, and in DIC, for that you have to compress more than 5 minutes at least, or see that there is no active bleeding or no hematoma formation inside the skin crease. Okay. So check sample for presence of small bubbles. Okay. So if air is there, you have to de-air it. Label the syringe. What in labeling, what will you do? You have to maintain, just write what is the pad number or patient name or MRD, whatever the facility you have. And the second thing is the FiO2 of that patient. FiO2 means when you take ABG, what FiO2 the patient is receiving. Means if he is having FiO2 of 80%, you have to mention the 80% FiO2. Or he is on reservoir bag or simple face mask, you have to write down 40% of FiO2. Or on room air, you just mention 21%. Take the sample immediately to the ABG lab for the processing. So keep in mind, immediately you have to process it, or if you don't have the facility, you can freeze it in the ice cold for 15 minutes at least maximum. And if you are increasing the time, you all know that RBCs will consume oxygen and produce carbon dioxide. So your ABG will be not much correlating to your patient condition. So recording of date, time, site of puncture, or any complications, you have to mention in your data sheet. So these are two videos that I think we should play it in just end of the slides, end of the lecture. Now coming to the clinical significance, means what is the clinical significance of doing an ABG? So if having a mild disturbances, means pH is between around 7.3 to 7.5, means it is just a mild disturbances, and you will find a mild symptoms or subtle clinical manifestations. If your patient is having in severe acidosis, like pH is less than 7.20 or H ions are more than 63 nanoequivalent per liter, and presenting with the, means your patient along with pH less than 7.2, your patient should have the features like poor myocardial performances, arrhythmias, hypotension, pulmonary edema, or hyperkalemia. These are all the symptoms happens due to your acidosis. Okay. And in case of alkalosis, means pH should be more than 7.5 and having the symptoms of mental confusion, muscular irritability, seizures, arrhythmias, and hypokalemia. So identification is difficult in a sick child presenting predominantly with the features of primary disease. So now firmly establish the severity of oxygen abnormality. Okay. So how will you establish this? By seeing the PF ratio. By seeing your PO2 oblique FiO2 ratio, means what if your ABG is having a PO2 of 90 and you are giving 21% of FiO2, so 90 by 90 upon 21. So it is 0.21, means should be more than 500 or 300. So if it is more than 300, 500, that means your patient is absolutely fine. or if it is having a PF ratio of less than 300, it comes in the category of ARDS. You can categorize it according to Berlin's definition, like PF ratio less than 300, 200, 100. And you have to, by seeing CO2, PCO2 levels, you can evaluate that patient is hyperventilating or hypoventilating. In hyperventilation, CO2 will wash out and CO2 levels will be decreased. So there is currently no convenient non-invasive way of evaluating PCO2. In high-end some ventilators, we have the calorimetric methods. By this, you can evaluate non-invasively your PCO2 levels, but this should not be the discussing points in this class. To determine acid-base status, particularly in patients with metabolic acidosis, to track the application of mechanical ventilation in critically ill patients. That means do an ABG, change your ventilator settings, and again do an ABG and change your ventilator settings. Means you can track your settings, that your just these settings of ventilation like respiratory rate, P, FiO2 pressure support is adequate or not for that patient. You have to increase what parameters you have to increase. You can select according to see your ABG. So also tells about the electrolytes as we already discussed, lactates. So now coming to the best part of this lecture, that is the ABG interpretation. So we'll discuss very basics that why you need step-by-step approach. Because if you go with that approach, you will not forget or miss anything in your ABG, the basic. So first you have to see pH. Okay, pH means is it 7.2, 7.3, 7.4, whatever it is. Now by seeing pH, you can say that it is acidosis or alkalosis. Now after seeing that, you have to jump on the cause. Means what is the primary pathology behind the disturbances of this pH? Means is it respiratory or is it metabolic? See, if PCO2 is rising or PCO2, then it is respiratory. If bicarb is a culprit, then it is a metabolic. So what is the primary pathology? Now, after finding that this is your primary pathology, respiratory or metabolic, then you have to see the compensation, that your metabolic part or respiratory part is compensating or not. Means stage of, then you have to see compensation. So the compensation can be, where ABG can be uncompensated, means the patient just in initial phase or body is just trying to compensate, means it is uncompensated or compensated. In compensated, it can be partially compensated or fully compensated. We'll discuss in details in later slides what is partially compensated and what is fully compensated. Now after this compensation, you have to see the oxygenation status. Okay, means what is your PF ratio, what is the alveolar arterial gradient. After this, you have to see that your ABG is having just a simple disorder. It is just a respiratory acidosis with a metabolic compensation, or is having both the components, like having a respiratory acidosis as well as metabolic acidosis. Okay. Now after this simple, you differentiate simple and mixed disorder. You have to see that this compensation is in acute stage or is it is chronic stage, just by memorizing the simple formulas that I will discuss in later slides. And lastly, there are some laboratory errors that you have in your ABG, or might be due to that your machine is not calibrated according to your. Now, these are some simple values that you have to remember. So what is a normal value of pH is, it should be between 7.35 to 7.45. Always remember this in decimal, 2 decimal values at least. Okay. So, and you can see the critical values will be less than 7.2 or more than 7.2. Means critical means severe. Now coming to what is the normal saturation level of SiO2 level will be 80% to 100%. Critical values less than 80%. And normal PO2, it would be around 80 to 100 mmHg on room air. Okay. So keep in mind, room air means what FiO2 you are giving, your PO2 is depending upon that FiO2. So maybe in a patient who is receiving room air and presenting with a PO2 of 80 is good, far enough good. But a patient who is having or who is receiving 100% FiO2 and showing your PO2 80 means it is not normal, it is abnormal value. Okay, so you have to see. So this PO2 value is on room air. Now coming to the PaCO2 values. So PaCO2 values is between 35 to 45 mmHg, and normal bicarb level is between 22 to 26. Means 24 plus minus 2. The simple formula. So, and what is base axis, or it can be axis or deficit. Okay, both. The value is in minus or in plus. So minus 2 to plus 2 milliequivalent. It is a normal value. See, this is just a simple photograph of our hospital, of our ICU, showing so many parameters, but we have to see these few parameters especially look for. Don't go hematocrit, calcium, DO2, PO2. So if you want to go in detail, you can get it, but go with the basics initially. You especially don't miss these 1, 2, 3, 4, 5, 6, 7 points. Okay, pH, PO2, PCO2, bicarb, saturation SiO2, base axis, and an ion gap. Now you can see here your pH showing normal value. If it is decreasing, it is acidemia, means acidosis. And acidosis just because it can be due to increase in PCO2, means respiratory, or decrease in bicarb because of metabolic. So respiratory cause and metabolic cause. Now coming to the alkalemia. Alkalemia, same thing. If PaCO2 level is less than 14 mmHg, it is respiratory. Alkalemia means your patient is hyperventilating, and if your patient is having low bicarb, means it is metabolic alkalemia. So same things. It is same here. It is just mnemonic, I think, ROMS. Okay, pH is decreasing because of metabolic and respiratory. If pH is increasing, can be due to metabolic and respiratory. So this is a few some examples you can see here. The pH is 7.25. Okay, means it is lower than lower sides, decreasing trend. 7.25 means simply acidosis. Okay, समझ में आप पता चल गया pH से 7.2 means acidosis. अब दूसरी चीज देखनी है कि प्राइमरी पैथोलॉजी क्या है. प्राइमरी पैथोलॉजी कहाँ क्या है? PCO2 50 तो बढ़ रहा है, means it is respiratory. Primary pathology is respiratory acidosis. Compensation, no compensation. because bicarb is normal. So it is simple respiratory acidosis. Same. Second, metabolic alkalosis. pH is 7.5. Alkalosis. PCO2 is normal. Bicarb is rising. So it is just a simple metabolic alkalosis. Now, this is uncompensated. Now we'll go to the compensation. So it can be uncompensated, can be no time for compensation in just the initial phase, or pH and one parameter is abnormal. Now compensation, how compensation occurs. So these are the phases of compensation. Body buffers come first. So it within minutes, the body buffers will compensate. Then respiratory within hours. And then lastly, the renal system, buffering renal system, loss of bicarb or conserving bicarb within days. So it will be a chronic. So now partially compensated or fully compensated means partially compensated means compensation process is incomplete and both the parameters will change in the same direction. And in compensated stage or chronic stage, pH will be your near normal or can be normal. Okay, we see here word is near normal with abnormal altered PCO2 and bicarbs. Now, these are few examples or how will you calculate acute or chronic. And you have to memorize it. Compensation by respiratory response. If your patient is having a primary pathology is metabolic acidosis, then compensation will be respiratory. So how will you predict what changes in PCO2 will be? So this is a simple formula, 1.5 into bicarb plus 8 plus minus 2. So if patient PCO2 is roughly this value, the response is appropriate. And if patient PCO2 is higher than this value, then they are failing to compensate adequately. In case of metabolic alkalosis, every 10 mm increase in bicarb will increase in PCO2 by 7. And now coming to the compensation by metabolic response means primary pathology is respiratory. In respiratory acidosis, for every 10 mm increase in PCO2, your bicarb will increase by 1 in acute condition, and in chronic condition, it will increase by 3. Means acutely it is 1 time and in chronic condition is 3 times. In respiratory alkalosis, every 10 mm decrease in PaCO2 value will decrease your bicarb by 2 in acute stage or by 4 in chronic condition. See, these are the values and these are the data. You have to remember it by your own. These are some examples of partially compensated metabolic acidosis or respiratory alkalosis. There are 4 examples you can see here. First is metabolic acidosis. You can see here pH is 7.25, PaCO2 is normal and bicarb is in decreasing trend. Means it is just a metabolic acidosis. Okay. Now you can see here the second example is respiratory alkalosis. Now the compensation starts, and this is the picture shows the partially compensated metabolic alkalosis. pH is 7.5 means increasing means alkalosis. Okay. PCO2 is 51 means it is increasing. Bicarb is 40 means increasing. Means both in the same direction. So it is partially compensated metabolic alkalosis. Now pH is 7.3 acidosis. PCO2 is 50 means respiratory cause. Bicarb is increasing means compensation partially compensated respiratory acidosis. Respiratory acidosis with metabolic compensation, partial compensation. Now coming to the fully compensated respiratory acidosis. These are some examples of full compensation. You can see here the pH value is decreasing means acidosis. PCO2 is 49, bicarb is 30. How you can say it is fully compensated? Because your pH is your near normal. Okay, so it is fully compensated. What is respiratory acidosis compensated with metabolic alkalosis? Now same here, pH is near normal means 7.45, less than 7.45, the value is near normal. So it is fully compensated. And what is this showing? PCO2 is in rising trend. Bicarb is rising. So both in the same direction. And this is the metabolic alkalosis with compensatory respiratory acidosis. Okay. So it is just don't confuse here, please. You can see partial compensation. You just have to differentiate partial or fully compensated by just seeing your ABG. Your pH. Means if it is near normal and compensation happening, means it is fully compensated. Now coming to the oxygen status. As we all know, depends upon age what FiO2 is giving. The normal PO2 value is between 80 to 100 mg in children as well as in adults, as already we discussed. Newborn, it ranges from 40 to 70 mg of Hg. On oxygen therapy, the value of PO2 will be high. That I already told you that it will be your 5 times of your FiO2. So oxygen supplementation should be below 60% to avoid toxicity. See, this is a very important point. We have to see it, especially in COVID scenario, and we are facing so many oxygen crisis in second wave. So we have to use our oxygen or our resources very judiciously. So don't be harm the patients as well as misuse or abuse of resources. So your target of PO2 or saturations will be around 95, 94. Don't be like I have to target is 9900. अब मुझे तो 100 ही करना है. ऐसा नहीं करना है. Your target will be around 94. In some scenarios, you can target little higher, like in trauma or in cardiac patients, okay, or in anemic patients. So anemic patients may have normal PO2 and saturation, but the delivery of oxygen to the tissue will be compromised. Why? Because delivery will depends upon multiple factors like DO2. DO2 will be depend upon your PO2, saturation, hemoglobin, and these all things. So general oxygen saturation must be measured by your pulse oximetry, as we all know. Now coming to the disorders, that it is just a simple disorder or mixed disorder. In simple acid-base disorders, both PaCO2 and bicarb change the same direction. Okay, if they do not follow this train, the possibility of mixed disorder is likely. The expected compensation for simple acid-base disorder is predetermined, and if they deviate from these norms, there is a possibility of mixed disorder. Now there are some few examples of mixed disorder. You can see here, this is your respiratory acidosis mixed with metabolic acidosis. pH is decreasing and bicarb is also decreasing. So primary pathology is respiratory, but bicarb is also decreasing. So it is a mixed disorder. Respiratory acidosis with metabolic acidosis. It is the anion gap is high. So high anion gap metabolic acidosis. What is anion gap? And you can measure an anion gap by adding sodium with potassium and subtract with chloride and with bicarb. So just a simple questions, if anybody want to answer it. It is a 6-year-old male child presented with the emergency with chief complaint of fever and abnormal body movement. For 2 days, ABG was showing this. pH is 7.39. You can see here, PCO2 is 40, PO2 is 74.5, bicarb is 22.1, base axis pointed. What is your diagnosis? So if anybody can want to answer, he or she can put into the chat box. Okay. Okay, I will answer it. See, you can see here, it is just a normal ABG. See, here you cannot say this is a normal ABG because you don't have the oxygenation status. Means you don't have the idea of what FiO2 your baby is receiving. So your patient can be hypoxic on that PO2 value. Okay, so otherwise that ABG is okay. So if someone gives you that ABG, you just first ask, sir, what is the FiO2 of that patient? What is the FiO2? What is the oxygen status of that baby? Because by only these findings, you cannot measure your oxygen status of that patient. So you can see here, another question is this simple. This is a 6-year-old child with the 5 days of rapid breathing since today morning. You did ABG and these are the results. So what would be you can write down in the chat box. We'll discuss at the end these questions. Now coming to what are the common problems onto the mixed disturbances. Severe asthma, shock, cardiopulmonary arrest. So in these like shock, arrest, you can have a lactic acidosis as well as respiratory acidosis. So you will find both type of disorders. In ARDS, in newborn, patients having diarrhea with vomiting, decompensated liver disease, patient is on diuretic therapy, on salicylate poisoning. There are a few examples you can see here. In asthma, what type of ABG you will find? These are all the mixed disorders. So in asthma, in diarrhea, in poliomyelitis, in vomiting, in respiratory distress syndrome, there are some common 5 examples I'm sharing with you. Like in asthma, your pH will be 7.6, PCO2 will be 30, bicarb will be on increasing side, PO2 will be on lesser side, on FiO2 21. Means your patient is having hypoxemia. You can see PF ratio is there. So it is a respiratory alkalosis with PF ratio of around 300. So it is a mild hypoxemia. In case of diarrhea, what you will have? pH is 7.24. The culprit is here, bicarb. So it is a simply partially compensated metabolic acidosis without hypoxemia. So you have to mention oxygen status also because PF ratio is more than 500. So it's good, no hypoxemia. In case of poliomyelitis, because of hypoventilation, you will find what? CO2 will be on higher side, means respiratory acidosis. 7.20 means uncompensated respiratory acidosis with PF ratio is around 150, means hypoxemia. So uncompensated respiratory acidosis with hypoxemia. The cause is ventilatory failure because the patient is having a disease of polio. So chest tightness and all will happen. So it is just because of that. In case of vomiting, you will have pH of 7.4, PCO2 will be around 55, bicarb will be your on higher side. So you can see here by seeing your pH, you can see it is fully compensated because the pH value is near normal and the culprit is metabolic alkalosis and compensation by respiratory because they are rising in the same direction. In case of respiratory distress syndrome, pH is 7.1 means uncompensated. PCO2 30 means it is near normal. Bicarb is 8, it's on lower side means metabolic acidosis with hypoxemia. 30 PO2, 60 FiO2 means almost inverse, means less than 100, means your patient is in ARDS. So take home messages our ABG plays an important role or a point of care testing in any sick child. So you have to know how to do it, when to do it, and how to interpret it. So life-threatening conditions like metabolic and respiratory coexisting with the pH or near normal, the role of serial ABG estimation is indispensable. That means in case of COPD and all, you have to do a serial ABGs like within 2 hours, 4 hours. If mixed,
Dr. Rajesh, can you hear me?
yeah, sir.
अभी लिख के आया कि voice is not coming, तो कोई problem. Can you all hear Dr. Rajesh?
Yeah.
Someone has written voice is not coming. Dr.
Voice is
Saurabh
not-
Srivastava. Dr. Saurabh, are you listening to Dr. Rajesh? Okay. Everyone is saying the voice is coming. Okay, go ahead, please.
Yeah. In mixed disorders, if the pH deviates occur in the same direction, chances of life-threatening complication are imminent. So, knowledge of ABG is essential for any physician, especially who handles a ICU or who is managing an intensive care unit or even an emergency department. So, you all must know the basic interpretation of an ABG, how to do it, what are the sites, what are the complications of ABG. So by this, my session will be ending. These are all the references. These are all the contributors of these presentations. So I would like to thank you all the contributors, and I would like to thank you all organizers of this event. Now we can take questions.
Yeah.
And thank you, sir. Thank you for coordinating and moderating the
Thank
session.
you, Dr. Rajesh. Anyone, any questions? Please ask. Dr. Radhika Kesarwani wants to see one of the earlier slides again.
Chat box is not shown. Yeah, more. Yeah. Sir, can you show previous slides again? Which slides, Dr. Radh?
Dr. Radha, which slide you want to see? How many? Can you specify some topic of the slide or how
Content?
much
Any content? Just let me know, please.
Content of the slide.
Or I can go through.
Dr. Radha, you can put on your microphone and speak, and then put it off.
Yeah. Table were showing acidosis and alkalosis cases.
Okay.
This one. Someone asked, how can vein be punctured during ABG? How to know this only on the basis of color or else? See, it is very difficult to interpret it on the color. But yeah, if you're getting a dark colored blood, means you're having arterial puncture. But so many times you can see it is very difficult to interpret it on color basis.
You want not Dr. Rajesh, not this slide, but the one which contains alkalosis and acidosis table. How many times ABG monitor? Someone asked if this is very difficult. That is why instead of ABG, sometimes it's not the purview of the talk, but we can use VBG to follow many things. But ABG monitoring, if you have arterial line, then you can monitor many times. To maintain the arterial line is difficult sometimes in some setups. So we'll have to see whether we have an arterial line in place or not. Otherwise, puncturing many a time LVB. That is why sometimes we have to use our questions are being answered by the pulse ox only. If they are, then we should not puncture unnecessarily. Otherwise, in case there is a case in which we need frequent ABG monitoring, we have to put an arterial line.
See how
Second
many
last slide. She's asking for second last slide.
yeah. This slide I am showing this. Yeah, this is see, but rather these slides are just some few disorders that commonly we are facing in day-to-day practice. Okay, not per se of children, but per se of adult or any patients. In these scenarios, what ABG will you find? Like in asthma, you will find a typical this type of ABG in vomiting, in respiratory distress syndrome, and in poliomyelitis, in GBS. And in these cases, you will find these type of ABGs. So someone asked how many times ABG monitor. See, ABG monitoring is depending upon what is the patient's clinical conditions. Like if patient is on your ventilator and you are changing ventilator settings. So every time you change your ventilator settings, you have to do an ABG to verify that your ventilator settings are appropriate or not. Otherwise, you can do a simple, just a morning ABG, and if patient is clinically all right, there is no need to do BD thrice a day and 4 times a day ABG. Okay, and if you are having an arterial angina, as sir told, you can do it. Otherwise, there is no need to prick every time the patient, because arterial puncture is very painful, as I told you, and because all of you have seen that there is a hematoma in right, then you will start puncturing on the left. Now the femoral turn, now brachial turn. So you have to see, do an ABG very judiciously. Someone asked, could we go back to the second case example, which has been to be discussed at last? Yeah. So for that, anyone have to voluntarily answer. Yeah, I think we are discussing of that questions, no? Yes. See, you can see here, someone wants to voluntarily answer. So you can see here, see your PO2 is 68. pH is 7.3, means acidosis. PSO2 is on rising trend, means respiratory. Bicarb is on rising, means it is alkalotic phase, means respiratory acidosis with metabolic compensation. Okay, means 4. Anything in chat box? How much blood can be used to buffer? I did not get this answer. Did not get. How much blood can be used to buffer the acidosis at a time? Sorry, I didn't know that answer.
No, this question is, please explain what you want to ask by this question, Dr. Amit.
Someone asked, will you like to emphasize the severity and need of intensive actions taken for measurement and threat of no return point in COVID-19 patients? I think Professor Gautam Anand sir, this question is very, like in broader terms, it is not related to our this ABG scenarios, and the answer per se is very actually differed.
For buffering, can I say something for buffering?
Yeah, sure,
Can I
sure.
add something? Dear Dr. Amit, buffering, we cannot wait for buffering because buffering is the first one which takes in within minutes. Even before we know there is some disorder in the blood gas, the buffering has taken place. So we cannot see and now start buffering. Every other thing starts after buffering. So blood cannot be used to buffer the pH.
Someone asked how to check validity of an ABG, how accurate is the method? Actually, for validity, you can see the clinical parameters of the patients as well as if your SpO2 and SO2 is correlating well, that means your ABG is all right. Or before doing interpretation, you have to calibrate your machine for any error. And how accurate is method? Actually, which method you want to ask? I didn't get.
There is one more important aspect of the question. This is a very good question which is asked by Dr. Rajesh Kumar Meena. So another important way to tackle this question is the pH is 7.30, definitely acidotic. PaCO2 is 63. So if the PaCO2 is 63, that means in case of Winter's formula, if it were a metabolic acidosis, the last two digits of the pH after point, that is 30, should match PaCO2. But PaCO2 is much more than that. That means this is not a metabolic acidosis and this is a respiratory alkalosis, but which is partially compensated by the bicarbonate. Isn't it? Last, in case of a metabolic acidosis, if it was, but in another case, bicarb is higher than 24, so it can never be a metabolic acidosis because we have to explain pH on the basis of basic either PaCO2 or bicarb. So PaCO2 is the sole answer. Rising PaCO2 is the sole answer to this pH, and it is metabolic acidosis. What is the relevance of base excess or base deficit? So base is there to buffer in case base excess is there. So total buffering has taken place, but the base excess or deficit have now been corrected. This is just the answer. So we have to intervene. Will you learn how to check validity of ABG? I have written the answer of this. How to check the validity of PaCO2? We could take the help of Henderson-Hasselbalch equation. See in the chat box. I have written the answer already. Isn't it? Let me check. Look, to see the veracity or feasibility of ABG is normal. The hydrogen ion should be equal to 24 into the level of PaCO2 upon bicarbonate levels. So the hydrogen ion concentration, we have all understood how to let's see the pH, and 80 minus the last two digits of the pH is the hydrogen ion concentration. Suppose the pH is 7.47, hydrogen ion concentration is 100. Suppose the pH is 7.40, hydrogen ion concentration is 80 minus 40, that is 14. So in this equation, 40 is equal to 24 into PaCO2 upon bicarbonate. So it should match 40 in case. So this is very easy. So it is in the chat box. Henderson-Hasselbalch equation is hydrogen concentration ion is equal to 24 into PaCO2 divided by bicarbonate concentration in the ABG. Then there is a question, will you like to emphasize the severity and need of intensive action taken for measurement and threat of no return point? I'm sorry, the question seems to be vague. Professor Gautam Anand has asked, but can sir please you elaborate your question, and in case you know the answer, please wisen us. Professor Gautam? Actually,
sir, very difficult to answer this question. Actually,
yeah,
it's depend upon patient to patient and even physician to physician. It will vary. That at what point of
what intensive action is being referred? Is it oxygen? Is it mechanical ventilation? Is it any other therapy? Is it correction of? So it's difficult, sir. You have to give a reference point. Which intensive action or group of intensive actions you are talking about? Then it can be cause, and always it is to be clinically seen what the patient condition needs, and how can we improve upon. So I think there are no open questions. Chat box is full of not answers, and there is no fresh, I think, chat occurring. Okay, what is the relevance of, we have talked about how does ECF and blood value correlation work? How does ECF and blood value? Dr. Rajesh, could you make out something of this question?
just a minute. What's the relevance of how does ECF and blood value correlation works? Actually, sir, I think Doctor, she wants to ask extracellular fluid and blood value correlation. No, actually, it will not work.
No apparent correlation. No apparent correlation.
There is no correlation between the extracellular fluid and blood value.
Actually, ECF is not a full representative of milio-anterior, while blood is. So while we are examining the blood by arterial blood gases or any other means, we are peeping into the milio-anterior. But ECF is some part of milio-anterior is represented by ESF, some is not. So we just cannot say that ECF will always represent the blood values. Thank you, Dr. Swati. I think very interactive session, Dr. Meena. You could.
Thank you very much, sir. Thank you, Siddharth, sir, for just inviting me and giving me the opportunity.
So, thank you so much. Now, with permission of the, all attendees and all organizers, we go on to the next talk or last talk of this session. Dr. Vedika Bhatt, I assume, is raring to go.
Yes, sir. Yes, sir.
And RM from RMC Bareilly. She will be talking about discharge policy and post-COVID care of children and adolescents. Equally important, very relevant topic. You are welcome, Dr. Vedika.
Thank you, sir.
Hello.
So is my slide visible?
Yes, slides are visible.
Okay.
And you are audible.
Okay, sir. Good afternoon, everybody. I'm Dr. Vedika, Assistant Professor Pediatrics from Royalton Medical College. So my topic for today is going to be the discharge policy and post-COVID care. So discharge is the point of maximum satisfaction in the treatment of the patient for a physician. And since COVID is a pandemic, so we are supposed to have a uniform discharge criteria. So the learning goals of today's session is going to be discharge policy, home care after discharge, and some point about post-COVID care. So the next.
Next slide, please.
Yeah. So there's some problem with the network. So the coming to asymptomatic cases. So when are we going to discharge asymptomatic cases? So asymptomatic cases are obviously not going to be admitted, but if because of a social eligibility criteria wherein the patient would not have a separate room and a separate toilet facility for quarantine of the COVID infected patient, in such cases, these patients will have to be admitted. So in such scenarios where a patient was asymptomatic and still had to be admitted because of the social eligibility criteria, these patients can be discharged on day 10 after the test was positive, because obviously the patient was not symptomatic. So we would discharge him after 10 days of the test being positive, or day 7 after admission, whichever is later. And in asymptomatic patients, no repeat RT-PCR or any form of testing is required before discharge. However, the patient will have to be advised that he follows home isolation for 7 days after discharge, right? With advice also regarding monitoring of the patient. See, because in pediatric patients, irrespective of the severity of whether the patient was asymptomatic or he was mild, moderate, severe COVID, there is something called as MISC, which can occur as a post-COVID complication after 2 to 6 weeks, which we will be discussing in later sessions, in day 3 or day 4 sessions. So there you will be able to understand that this complication can even occur after post-COVID, that is after a gap of about 2 to 6 weeks. So a special note regarding monitoring for the signs of MISC also has to be told to the parents, like a recurrence of a fever, or if there is a high-grade fever for more than 3 days along with some new onset of symptoms, then they could have to report immediately to the treating physician. So even in asymptomatic patients, this particular guidance would have to be given. Now coming to when will we discharge the mild category patients. So even these patients will not require admission. They will be advised home isolation. So as discussed in the previous day session, the mild category cases will not be admitted unless again they have social eligibility criteria which is not being met. That is, there's no separate room and a toilet for quarantine. Or in case of patients with comorbidities, like a patient with CLD or a patient with obesity, all the comorbidities which were discussed in the previous days sessions. So if any comorbidity is there and the patient is not able to take a definitive healthcare at immediate purpose, so he is apprehensive that he will not be able to monitor the patient at home. So in case of such scenarios, you may have to admit even if he is mildly symptomatic. So such cases, if they are admitted, then they would have to be discharged after day 10 of being asymptomatic or the test was positive, and day 7 of admission, whichever is later. Again, here, no repeat testing would be needed. However, mandatory home isolation and monitoring of the patient should continue even after discharge. Then coming to the moderate category cases. So these are the patients who we are going to admit. So they will form the majority of the patients who will be requiring hospital admission. So these patients will be discharged when the patient does not need supplemental oxygen. So our patient is off oxygen, is maintaining saturation above 95 without an oxygen support, and the patient is asymptomatic, that is completely symptom free, or he has mild symptoms which do not require persistence of his hospital admission, such as he has loss of smell, or there is some throat irritation which can be does not require him to be hospitalized and require admission. In such scenarios, you can discharge the patient. And here you have to do a repeat test, and that repeat test is negative. And after that, you also have to examine the patient for any other comorbidities which may require him to be prolonging his hospital stay. He may be having anemia, or he can be a patient of PEM, or he can be a patient with some comorbidities which require some time to stabilize. And for that particular indication, he requires to be hospitalized. Then his hospital admission has to be continued. So that will be decided by the treating doctor. So a thorough examination by the treating doctor to rule out any other condition which requires him to be still admitted has to be taken care of. Then again, during the time of discharge, the patient will have to be properly advised regarding monitoring. These things have been already discussed in the previous day session, that the patient's attender will have to be told about how he has to count the respiratory rate at least 2 to 3 times a day for 1 minute in a non-crying child. So the parent should be made to understand that how they are supposed to count a respiratory rate. And you have to guide them that how the respiratory rate is going to be counted so that they don't misinterpret in a crying child or in an apprehensive or an anxious child that there is tachypnea. So at least 2 to 3 times a day, they should be able to take the respiratory rate, take the oxygen saturation and temperature monitoring. So proper advice regarding these 3 parameters along with any new symptoms which can be relating to MISC also will have to be advised to the caregivers and they can be discharged. Now coming to severe category cases, the severe category cases obviously will require ICU admission till the intensive care phase is completed. So till they require intensive care, they will be in the ICU. Then they will be shifted to the step down so that the ICU beds are obviously limited and they can be utilized for patients who are more critically sick. So once the patient is out of the critical situation, then he can be shifted to the step down ward. And these patients from the step down will be discharged when they do not need supplemental oxygen. That is, they maintain a saturation above 95% on room air and they are asymptomatic or mildly symptomatic. As I previously told you, the symptoms are so mild enough that they do not require to be hospitalized and a repeat test is negative. That is, a repeat RT-PCR is negative. And as discussed previously, a thorough examination should be done for any other condition which warrants persistence of his hospital stay. And again, the patient has to be advised regarding home monitoring. So this is a very important aspect of discharge, that is home monitoring. So even if you have discharged the patient, a thorough counseling of the parents that they have to monitor respiratory rate, follow quarantine practice for another 7 days and have a COVID appropriate behavior, maintain social distancing, etc. Hand washing, then counting the respiratory rate, oxygen saturation, temperature of the child at least 2 to 3 times a day, and any other ominous or red flag signs if they are there in the child or any new symptom has arisen which is looking ominous, then they have to report to the healthcare facility immediately. Now, what else advice will be given to these patients with severe COVID? That is mandatory home isolation for minimum of 7 days, using of masks to prevent infection to other family members. This is to all the patients, all the discharged patients, severe, moderate, mild, whichever patients are discharged. So these advice are common to all. Then hand hygiene has to be followed by all of them. Then the clothes which are used during the hospital stay needs to be disinfected by a hydrogen peroxide 0.5% or a sodium hypochlorite of 0.1% because they are fabric. So you will use a lower concentration of sodium hypochlorite, that is 0.1%. And then you have to disinfect the mobile phones, the footwears which are being worn by the patient, the other things used during hospital stay with an alcohol-based hand rub or a hydrogen peroxide, whichever is feasible. Then clothes worn during the time of discharge needs to be washed with a hot water and a detergent, and then they should be air dried. So hot water has to be used for disinfection purposes and a detergent may be used. Then parents also need to sign a declaration to follow home isolation and other precautions, and the parents need to be counseled regarding monitoring of symptoms, and if any ominous symptoms or any attention is required, they have to report immediately to the helpline services or the COVID care center. Now, what post-COVID care do we require? This post-COVID care is going to be a holistic approach. So other than medical support, you also need to give emotional support. See, when a child is there in a hospital status as hospitalized, and especially when he is in ICU with a ventilator and the lines in C2, it is a lot of emotional and psychological stress, something called as a post-traumatic stress. So these child can go through an emotional turmoil. They can have the memories of their hospitalized state and can be a bit depressed. So they require medical attention and they require psychological attention also. That is the emotional support also. So it needs to be a holistic approach. The parents or the caregivers also need to be told about how to take care of the mental health of the child, right? And if need arises, they can be referred to a mental health expert for further guidance. The recovery period may be longer in patients with moderate and severe symptoms and those with comorbidities. So they have, as I told before, they have to follow a COVID appropriate behavior even after discharge. That is hand hygiene, respiratory hygiene, and social distancing. These are the important pillars. Then the caregiver should also be advised that the child should be well hydrated, right? So hydration status of the child has to be maintained. And the child can also resume his pre-COVID activities gradually. So initially he can be indoors and then gradually do whatever pre-COVID activities he was doing. Immunity promoting Irish medicines, we are not supposed to prescribe as a routine, but yeah, you can definitely recommend some of the home remedies like ginger, etc. Then mild exercises and games can be advised to promote the mental health status of the child. Nutritious, soft, fresh, and home cooked food. That is an essential part, the dietary rehabilitation or the dietary counseling, that the child should be given soft, fresh, and home cooked food, not a junk and not high oily food has to be avoided. Easily digestible, non-spicy food, which is home cooked and fresh rather than frozen, has to be advised. Definitely dietary advice regarding the comorbidities will have to be given separately. See, you cannot cover all the topics, but like if the patient is a PEM, then the according dietary advice has to be given. If he's a SAM, if he's a patient of chronic kidney disease, so appropriate dietary advice regarding a high protein and high protein salt restricted diet, etc. has to be given accordingly. Then adequate rest and sleep has to be advised. Regular medication depending upon the pre-existing illness, as I already told you, the comorbidities has to be addressed separately from the dietary prescription for the comorbidity, as well as the medications which are being prescribed for the comorbidity like a CKD or a CLD has to be taken care of at the time of discharge. Then monitoring of symptoms, this is the one thing we are keeping on reinforcing again and again, which is very important in pediatric patient, especially because of a complication that is MISC. Then you have to look for early warning signs like recurrence of fever, breathlessness, fall in saturation, which could be an ominous sign and may warrant evolution of MIS-C. Then monitor for temperature. Blood sugar monitoring has to be done if the child is diabetic. Oxygen saturation definitely has to be checked. Then if the child has a mild cough or a sore throat persisting, then steam inhalation can be advised, but not for all the patients. So if a patient is very small, you would avoid steam inhalation, but if it's an adolescent or adult patient who can safely take a steam inhalation, you can advise him. Saline gargles, yeah, they are definitely safe, but age has to be taken care of. So if it is feasible, then you can advise saline gargles. Cough medication routinely need not be prescribed, only if there is some wheeze, etc. Accordingly, you can prescribe the cough medications. So at the community level, what can we do? So as I told you, it is a lot of emotional trauma also to the child, apart from the medical ill health. So you definitely have to give them psychosocial help. So psychosocial counseling has to be done. Then you can refer them to self-help groups and counselors for this particular problem. The parents have to be told not to stigmatize about this mental health issues, and they have to be told that they have to take mental health support service help if they require, rather than being ashamed or stigmatized about it. Then parents of recovered children or recovered adolescents can also be advised to share their positive experience with other members in the family and society, so that whatever threat is there regarding COVID, that it is a deadly disease and all that myths, etc., can be removed from the mind of the public. So you have to create awareness, dispel myths and stigma about COVID, and that if you seek proper medical attention at a proper time, COVID has a good recovery rate. That is what a positive feedback you need to give to the public, so that their anxiety and apprehension is dealt with. So follow-up visit at the healthcare facility from where the patient was discharged, either physically if it is possible or telephonically within 7 days. However, patients with severe category cases may require stringent follow-up depending upon how severe the scenario was. And they can also be told to contact the healthcare facility if they have any new development of symptoms. So that ends my topic on discharge policy. I would like to take any questions if are there. I thank the contributors of the PPT and the program for giving me this opportunity. Thank you, sir.
Hello, Dr. Vedika, there is a question, let me read it. Whether whether distilled water or normal saline inhalation is preferred. Okay, this doesn't belong to your talk. I think distilled water is not. Normal saline inhalation is preferred because distilled water can cause excoriation. Normal saline because it is isotonic. Dr. Radha Kesarwani, are you listening? I will type the answer. Normal saline for all. Okay. Any other question? So without this, we come to the close of today's session. And it has been great with great speakers, Dr. Vedika and Dr. Ankur and Dr. Rajesh. So thank you all the contributors who have made the slides, all the speakers, and of course, all the panelists and all the listeners. You have been very, quite involved, and sessions have been interactive. Thank you so much. And we look forward to the another day's session. Thank you.
Thank you.
Okay. There is a question again, which IV fluid cannot be given rehydration? Usually we prefer isotonic fluids, in which comes normal saline or Ringer's lactate. In rehydration, if there is possibility of raised intracranial tension, then we always use normal saline for resuscitation of the fluid. And glucose containing fluids usually are not used for resuscitative purposes. Believe there is no other question. Thank you all. Thank you very much. And calling the day off. Thank you, Mamta ji and your team. Thank you very much. Very supportive you have been. ममता जी, प्लीज मुझे कल के लिए और परसों के लिए भी वो भेज दीजिएगा, मुझे अटेंड करना है, बहुत अच्छे सेशंस होते हैं, तो मुझे इनविटेशन भेज दीजिएगा प्लीज. आर यू लिसनिंग?
यस सर.
हाँ प्लीज मुझे कल परसों के भी भेज दीजिएगा. मैंने चंद्रकांता मैम से बात कर रखी है. ठीक है.
ओके सर. ओके.
थैंक यू सो मच.